Good afternoon and welcome back, everybody. We shall be starting the post-lunch session in 5 minutes. I request everybody to rejoin. Thank you.
Hello. गैलरी गैलरी में जाओ.
Good afternoon and welcome back, everybody. I hope everybody is joined back. We'll wait for a few moments so that everybody is to relog in. I request all the dignitaries and my co-parallels and my dear friends to please rejoin. Welcome back, everybody. We'll restart our session with the presentation of Dr. Harshal Ramteke sir, who is a professor at Department of Surgery, JNMC Varda. Topic for his discussion today would be fistulizing Crohn's disease. Sir, handing over to you. Dr. Ramteke sir, if you could please begin your presentation, sir.
Yes. Thank you all for giving me the opportunity to speak on a more elaborate topic of like Crohn's disease. And I hope that this topic will not going to lead you for a post-lunch, post-prandial sleep like that. I think it could be helpful from resident point of view also. As the topic is very vast of Crohn's disease involving all the GI system, like from the oral cavity to the anus, I will going to focus more on the anorectal area. So I am covering this topic in the form of visualizing Crohn's disease involving the anorectum and the perianal areas, keeping the colon and the small bowel part. So what is Crohn's disease? It's a, as you know, all you know, it's a chronic inflammatory disorder of the GI tract that can result in strictures, inflammatory masses, fistulas, abscesses, hemorrhage, and even cancer formation also in a long-standing disease. It may affect any region of the GI tract, right from mouth to the anus. It often involves multiple areas simultaneously, from small bowel to large bowel to the perianal areas like that. And the characteristic diagnostic on histopathology is it shows a transmural inflammation with multiple lymphoid aggregates, mostly in the submucosa and the mucosa. Crohn, Greenberg, and Oppenheimer first identified the disorder as a unique clinical entity in 1932. The exact cause for this disease is unknown, but it is said to have some prevailing theory in the form of multifactorial, like genetic predisposition of CARD15 or NOD2 mutation of a chromosome 16q. Some triggering factors, environmental, like excessive and continuous smoking. Some infectious possibility is also put forward as a prevailing theory, like Mycobacterium paratuberculosis, Pseudomonas, and Listeria. And not least is the immunological factors also to particular antigen either through diet or through the microorganism. So Crohn's disease can manifest in many different ways, like fibrostenotic, that is stricturing. Another way of manifestation is non-perforating, non-stricturing disease, which is more of an inflammatory in nature. And third way is predominantly perforating disease, which can lead to the fistula formation, either internal or external. So out of these three, the fistulizing Crohn's disease is more aggressive disease, and hence there is an increased morbidity and even can lead to mortality with the sepsis. So, yeah. Bissell was first to recognize the anorectal component of Crohn's disease. He recognized as one of the most challenging aspects of patient who has Crohn's disease. The common perianal manifestations, they include edematous skin tags, that is elephant ear-like presentation. Then one can have an hemorrhoids also, blue discoloration of the anus, recurrent abscesses, fistulas. Even fissure is also common. The characteristic of fissure formation in a Crohn's disease is they are most often multiple, off the midline on the lateral aspect, very much deep, and with associated large skin tags as compared to acute fissure. And usually it is painless. If patient present you with a pain with the underlying fissure and Crohn's, it usually suggests it's the pain is not because of an what you say anus person or fissure, because of an underlying abscess formation. So that pain is usually dictates that the patient might have an underlying abscess formation along with the fissure also. If Crohn's disease is long-standing and neglected, then it can often have lead to the stenosis or stricture formation of the anal opening also. Now the fissulas, we divided, sorry, either it could be external or internal. External comprises of 2/3, while internal is 1/3. External, they are either enterocutaneous or perianal, and internal, they are usually enteroenteral or enterocystic. The external fissulas, they are associated with pain, abscess, and drainage, while internal, they are frequently asymptomatic. Hence, they are difficult to diagnose because of asymptomatic in nature. The perianal disease and fistula can lead to abscess formation, fecal incontinence, and anal stricture also. The estimated incidence of fistula, either enterocutaneous or perianal, in patient with Crohn is approximately 35%. Approximately 21% of patients with Crohn will have perianal fistulas within 10 years of diagnosis. Internal fistula, as I say, are often silent, but they are common, like your external fistulas also. In a study by Michelesi and colleague, 1/3 of all patients undergoing an surgery for Crohn's disease were found to have internal fistulas. Of those patients, 69% with enterovesicular fistula, they had symptoms of internal fistula like pneumochuria or feculuria. In other 147 patients with internal fistulas, only 54% had an accurate preoperative diagnostic evaluation, either radiographic or endoscopic. Before the introduction of biological agents in a newer way of medical management, most fistulas, they require surgical intervention initially. Now, however, the rate of fistula recurrence post-surgery was estimated to be 30%. About the relevant anatomy, the anal canal is formed by 3 layers. The internal anal sphincter, which is made of smooth muscle of the rectum. Then we have an intersphincteric space in between the two internal and external anal sphincter. And external anal sphincter, which is comprised of skeletal muscle arising from an extension of the pipi rectalis and levator ani muscles. The dentate line is the midway point of the internal anal sphincter. It is the area that marks the interface of the columnar and transitional epithelium of the rectum from the squamous epithelium of the anus. Within this area, one finds the anal crypts with anal glands located at the bases of the crypts. Now, the pathogenesis of a fistulizing Crohn's disease, there are 3 hypotheses which is put for the pathogenesis. The first is there is a transmural inflammation as a characteristic feature of Crohn's disease. Then this inflammation penetrates into the adjacent organs, tissue, or skin. And this will lead to finally a fistula formation. And this commonly at the site of a stricture of the Crohn's disease. And this stricture also may represent a Peyer's tract. Based on the location and connection with the contiguous organs, as I mentioned, that fistula may be either enterovesicular or enteroenteric. Another hypothesis is there is a formation of ulcer within the anal canal, and feces are forced into this ulcer, which will lead to the penetration of the lesion through the wall, and this will lead to the tract which extends over time with increased pressure from the fecal stream. Another hypothesis is quoted is a formation of abscess is one of the anal glands within the intersphincteric space, and this abscess gradually grows if it is not treated or recognized early, and finally it will leads to the area of purulence under pressure, and finally it will burst out and form a fistula formation. And this fistula formation either could be transsphincteric one, which tracks through the external anal sphincter. It could be intersphincteric one, which tracks down to the skin directly from the intersphincteric space, or it could be suprasphincteric one, which tracks upwards. Now this is the pictorial representation of the types of fistula, which is usually anatomical classification based on a Park classification. There we have 5 types of fistulas. The first one is the superficial, which directly extend from the anal gland to the skin only. Then we have an intersphincteric fistula. Then we have a transsphincteric one, suprasphincteric, and extrasphincteric. Now, this anatomical classification uses the external sphincter as a central point of reference, which includes 5 types of perianal fistula, as I mentioned. Intersphincteris, which tracks between the 2 sphincters, transsphincteric, from the intersphincter space through the external sphincter. Then you have a suprasphincteric, which leaves the intersphincteric space over the top of the piperectalis and penetrates the levator muscle before tracking down to the skin. Then you have an extrasphincteric one, which tracks outside of the external anal sphincter and penetrates the levator muscle into the rectum. And lastly, a superficial one, which tracks both below both the internal and external sphincter complexes. Now, why it is important to classify and focus for the anatomical classification? Because it is important to diagnose and categorize fistula correctly, as correct categorization impacts which treatment modality will be most useful or successful in an individual Crohn patient which present you with a anorectal fistulizing disease. Another classification, which is not an anatomical base, mostly of a clinical base, is the American Gastroenterological Association classification, which was developed in 2003. A simple fistula or a complex fistula. The characteristic of simple fistula are they are superficial, they begin slow in the rectal canal, not associated with an abscess formation, does not connect to other structures such as vagina or scrotum, and there is no associated inflammation of the colonic mucosa. This is the pictorial diagram showing the simple fistula formation without any associated symptoms. The complex fistula, on the contrary, they are deep in nature. They begin high in the canal, associated with an abscess, or they have multiple openings or connect to an adjacent structure. Also, there could be presentation or a concomitant inflammation of the colonic mucosa. This is the complex fistula showing of a high nature with associated abscess formation. Now, the Park system, out of this, Park system is the most accurate method of describing fistula anatomy. However, there are several limitations to this system, including the fact that associated abscesses and connections to other structures such as internal organ or vagina or bladder, they are not part of this classification, but they are very much clinically important while considering and diagnosis and considering the treatment option of the patient. While American Gastroenterological Association classification is more clinically relevant because it considers the complex fistula, which involves more of the sphincter complex with reduced chance of fistula healing. They place patient at increased risk for incontinence and requires aggressive surgical interventions. Now, what are the diagnostic modalities for assessing fistulas? Occult abscesses or fistulas are difficult but important to recognize. Missing occult lesions can result in recurrent fistulas formation or abscess or conversion of a simple fistula into a complex fistulizing process. Once the fistulizing process becomes complex, the chance for healing is reduced greatly. Hence, it is important to identify and optimize the medical and surgical treatment early at the disease onset. Initial diagnostic modalities for assessing fistulas. The initial assessment is by a simple digital rectal examination. Although, because of the associated induration and scarring, the accuracy of this examination in defining fistula anatomy is reportedly very low, of 62% only. Hence, imaging should be used as a means to provide a therapeutic roadmap to ensure that all potential areas are treated. Imaging modalities that have been used to assess perineal fistula, they include fistulography, CT scan, pelvic MRI, and rectal endoscopic ultrasound. Fistulas must be defined fully, so appropriate therapy can be started. The goal is to establish drainage of any abscesses that may be present and control fistula healing to prevent recurrent abscess formation during treatment of a fistula. Fistulography, it can be painful. There is a theoretical potential for dissemination of septic fistula's content, which is very less clinically, but there is a theoretical potential of spreading of a sepsis. A low overall accuracy for determining the type of the fistula in the range of 16 to 50% only. Even CT scan has a limited role because of poor spatial resolution in the pelvis. Also, the accuracy is low, ranging from 24% to 60% only. The most accurate investigation to evaluate perineal Crohn's fistula, either it could be an MRI or a rectal ultrasonography, endoultrasonography. Schwartz in 2001 studied a prospective blinded study which compared the accuracy of MRI, US, and examination under anesthesia in 34 patients with suspected Crohn's perineal fistula. And in this study, they quoted the accuracy of US of around 91%, MRI of 87%, and evaluation under anesthesia of 91%. When any of the imaging modality of either US or MRI is combined with EUA, the accuracy can be reached up to 100%. And this is also one of the most cost-effective approach. Now the treatment options. After a fistula has been assessed properly and categorized, whether it is simple or complex, the most appropriate treatment course can be determined. And the decision can be taken between whether patient is taken for only for a medical therapy, like till in the simple fistula also only, or a surgical therapy, or a combination of post-surgical and medical therapy, which is determined by the type of fistula and the degree of rectal inflammation, how much the degree of rectal inflammation is there at the type of presentation. Medical treatment, sulfasalazine, mesalamine, and steroids are ineffective in controlling fistulizing Crohn's, not of a active Crohn inflammation like in small bowel and all that. They are the one of the mainstay of the treatment of as a first line drug. But for a fistulizing Crohn, it is ineffective. Antibiotics, short-term clinical improvement can be seen because of an control of perineal sepsis, but the healing of fistulous tract is very less for an antibiotic coverage, but there is a control of perineal sepsis. The most common antibiotic used are ciprofloxacin at 1 gram to 1.5 gram per day for up to 2 to 4 months, or metronidazole in a dosage of 750 to 1 gram for a month of 2 to 4 months. Next medical therapy is the immunomodulators. It involves thiopurine terate in the form of 6-mercaptopurine or azathioprine. They have been suggested to increase the speed of healing of the fistulae. 54% response rate is seen overall. A meta-analysis of trials looking at fistula closure as a secondary endpoint found that 22 of 44 patients, that is 54% of patients with perianal Crohn's disease who received azathioprine or 6-mercaptopurine responded versus only 6 of 29 patients, that is 21 patients who received placebo only. So for a medical line of management, antibiotic, as I mentioned, such as ciprofloxacin or metronidazole, they often used as a first line agent. Steroids, aminosalicylates, and immunosuppressive medications like azathioprine, they are easier and safer to use with the ability to monitor levels. Immunomodulators such as monoclonal anti-TNF antibody, which I cover in the subsequent slide, and azathioprine, they have found to heal up to 71% of perineal fistulas and 79% of ulcer and fissures in patients who have Crohn's disease. In a study by Tejako and colleagues, antibiotics were used along with immunomodulator therapy. The use of metronidazole or ciprofloxacin induced an early response of which is defined as at least 50% reduction in the number of training fistulas at week 8, with fistula closure occurring in 25% of cases. In patients who received additional azathioprine therapy, the response was better, that is 48% as compared to 15% at week 20. Most of the patients in this study had simple fistulas, and only 9 of the 52 cases were classed as complex fistula. So this could not be recommended to each and every patient because the study usually covers most of the patient of a simple fistula. So the success rate and the percentage of reduction is quite high in this study because it is covering more of a simple fistulas. Tumor necrosis factor antagonist, TNF. Prior to the introduction of anti-TNF antibodies, the goal of treatment was primarily control of symptoms in order to improve the patient's quality of life. With TNF antagonists, it is realistic to strive for complete fibrosis of fistula, especially in those patients with simple fistulas. The various agents which is recommended and used for therapies, the commonest is the infliximab, which is a mouse-based or a chimeric IgG1 antibody against alpha TNF. Next is the adalimumab. It is a fully humanized recombinant IgG1 monoclonal antibody against TNF alpha. And third one is the certolizumab pegol, which is a recombinant Fab antibody fragment against TNF alpha. 2 double-blind placebo-controlled trials of an anti-TNF antibody with a primary focus being on fistulizing Crohn's disease. In both of these trials, is based with the infliximab. 94 patients were randomized to treatment in infliximab of 5 mg per kg and 10 mg per kg or placebo. Patients were given an infusion at weeks 0, 2, and 6. The primary endpoint, that is greater than or equal to 50% reduction from baseline in the number of training fistulas. The result shows a 68% response rate, that is achievement of primary endpoint in the 5 mg per kg infliximab treatment arm compared with only 26% in the placebo. The ASCENT-2 trial, that is a Crohn's disease clinical trial evaluating infliximab in a new long-term treatment regimen in patients with fistulizing Crohn's disease. They investigated whether cessation of fistula drainage could be preserved over the course of a year with infliximab maintenance therapy, which is given every 8 weeks. After 54 weeks of therapy, 36% of patients in the infliximab group, they maintained a complete fistula closure compared to only 19% in the placebo arm. So one can think that long-term maintenance therapy of the infliximab can give a positive result of a complete fistula closure. Tacrolimus, a complete fistula closure, however, was only achieved in 10% of patients who received tacrolimus. The use of tacrolimus requires regular monitoring of renal function and drug level, which limits its ease of use. The same with the cyclosporin also, the toxicity profile may preclude use for the fistulizing disease, which given safer and better tolerable alternatives in the form of infliximab or adalimumab. Now, this is the treatment pyramid of medical and surgical of a step-up pyramid. which start from the base from antibiotic to 5-ASA treatment. And as the disease severity progresses, the addition of prednisolone steroid with a thiopurine derivative, and finally the TNF antagonist in the form of inflamac, and finally, lastly, as a surgical combination. As the disease severity increases, the treatment addition is added in a step-up pattern. But with the recent advent of and with a good result of your anti-TNF antagonist and all that, there has been nowadays debate or choosing a step-up approach or a top-down approach in the treatment of Crohn's disease. The top-down approach advocates aggressive therapy with TNF alpha before steroid because many eventually progresses to surgery, have frequent hospitalization and poor quality of life. So the top-down approaches advocates the aggressive therapy or starting of the infliximab or TNF alpha blocker right from the beginning of the disease process rather than stepping up from antibiotic and prednisolone. It is proposed that similar to rheumatoid arthritis therapy, a disease-modifying approach adopted early on in the course of disease may prevent future complications. However, no large trials have been published examining initial therapy infliximab. Due to concern of long-term toxicity and complication, top-down approach has not become the standard of care. Other miscellaneous non-surgical therapies, they include a hyperbaric oxygen therapy, elemental tides, TPN, mycophenolate mofetil, and thalidomide, and granulocyte colony stimulating factors. They all is used, but have been reported in an uncontrolled less case series or in a small number or individual case reports has been effective for treating perianal Crohn. So no control trials, however, exist. So it is not recommended or not used in a proper way. Now, surgical therapy. Surgical treatment is an integral part of treating physiologic Crohn's disease. It has been shown that the combination of medical and surgical therapy results in best outcome of this patient. The most common surgical treatment option include evaluation under anesthesia, which involves probing of the fistula tract. Another is the seton placement, incision and drainage, fistulotomy, fistula plugs, and fibrin glue. Seton, the placement of a draining seton maintains fistula drainage until the tract becomes inactive on medical treatment. A non-cutting seton or draining seton is threaded through the fistula tract and is tied outside the anal canal. The seton can be removed when the fistula tract has healed, or it can remain in situ for an extended period if healing has not occurred. Fistulotomy, it's a lay opening of the fistula tract can be done in patient with superficial or low perianal fistula who do not have active inflammation in their rectum, that is simple fistula, can be treated safely by fistulotomy alone with a resolution of fistula symptoms up to 85%. Fistula plugs or prioprosthetic plugs made from porcine intestinal submucosa also have been used in several studies, but with mixed results. The Surgisis fistula plug has shown up to 80% success rate with simple fistula. Fibrin glue also has been attempted to control fistula in Crohn's disease. Results have been varied from 0 to 80%. The variability can be attributed to the different types of fistula treated, both simple or complex, and the adjuvant therapies used with the glue. Abscess associated with fistula must be drained in order to achieve healing. The surgical approach can include local incision and drainage, catheter drainage, or seton placement. According to the recommendation of the American Society of Colon and Rectal Surgeons, anal abscesses should be drained in a timely manner. Lack of fluctuation should not be a reason to delay treatment, so one should not wait till the appearance of fluctuation. At the initiation of induration only, one can go ahead with the treatment. Another modality is the endoanal advancement flap procedures, mostly for a rectovaginal fistula, which occurs in 5 to 10% of females with Crohn's disease. Advancement flap procedures have been attempted as treatment for perineal fistula with good initial healing rates of up to 89%, but recurrence was found in 34% of this patient during follow-up. Either it could be done with an anocutaneous flap, vaginal flap, or Moshe's graft, which is based on a labia majora. Now, this is the final treatment modality. Treatment algorithm. To summarize, if patient present of a Crohn's disease with a anorectal visualizing presentation, the first and foremost is a proper history and physical examination. Then do the endoscopy to assess activity of the Crohn's disease. Simultaneously, do the imaging study either in the form of US or MRI to delineate perianal disease process, and do the exam under anesthesia. And evaluating with this 4 modality, if the fistula is simple and without rectal inflammation, then one can start antibiotic and azathioprine. One can consider as a top-down approach the anti-TNF at the same time as a top-down approach. But if you consider a step-up approach, then antibiotic and azathioprine only suffices. If there occurs a treatment failure in spite of this combination of antibiotic or azathioprine, or even considering an anti-TNF at that time, then one can consider a surgical option in the form of fistulotomy. Other alternative, fibrin glue, fibrin plug, or advancement flap. In spite of failure of fistulotomy and endorectal flap, then we have to consider this as a complex visualizing process and start a treatment as a complex visualizing process. If there is a success in the treatment with a medical therapy only, then continue the maintenance of azathioprine and anti-TNF if started. If the fistula is simple but rectal inflammation is there, then antibiotic, azathioprine, and anti-TNF is added. And with this, we have to consider a monitoring whether the fistula is healing or not with a repeat imaging study with the 2 course of the treatment. If the treatment success, continue maintenance. If it fails, treat it as a complex visualizing process. A complex fistula is treated either with a Saturn placement, surgical approach, along with a combination of a antibiotic or medical and azathioprine and anti-TNF therapy. With the addition of this anti-TNF and azathioprine, we have to consider a monitor healing and the side effect with a repeat imaging study. If treatment success, remove Saturn, continue maintenance, azathioprine and anti-TNF. If there is a failure of treatment, now consider and think of a tacrolimus in a selected patient, and finally a surgical in the form of proctectomy. So fecal diversion or proctocolectomy is nowadays, with the advent of these medical therapies, is reserved for patients with the most severe rectal disease only, that is refractory to other more conservative approaches. Now, risk factors for clinical recurrence, as it is you know about that Crohn's disease is located in some multiple location, and it is more prone for a recurrence. So the various risk factors they consider for a clinical recurrence is the continuous active cigarette smoking, surgery for the perforating indication is an independent predictor for early recurrence. If at the presentation only, if the patient presented with a perforating type of Crohn's disease in the form of fistula and surgery has undertaken, then it becomes an independent predictor for early recurrence also. Involvement of the small bowel was associated with an increased risk of recurrence requiring another surgery. That is the third risk factor. Fourth one is the surgical techniques of anastomosis have also been studied to study the recurrence of the Crohn's disease. In several studies, side-to-side stable ileocholic anastomosis was associated with a lower risk of recurrence than hand-swan anastomosis. In one large case control study, ileocholic anastomosis that was made in a side-to-side stable fashion was associated with 24% recurrence rate, which was significantly lower than the 57% recurrence rate in the group with conventional end-to-end hand-swan anastomosis. So with this surgical technique, it is preferred to have a stapled anastomosis as compared to a hand-swan to prevent the risk of recurrence. Now, this is the flow chart showing the risk of post-operative recurrence. Either it could be very low, low or moderate one, or high one. The very low risk of recurrence, they include the patient who have a long-standing Crohn's disease of more than 10 years of duration, first surgery at the time of presentation, and the stricture is of a short in length. While the low or moderate group, they involves less than 10 years of Crohn's disease duration, long stricture, or inflammatory Crohn's disease. While the high group, they include a penetrating disease, or at the time of presentation, the patient is having more than 2 surgeries. So in a very low group, no medication is required, only close follow-up in the form of colonoscopy in a span of 6 to 12 months post-operatively. If there is no recurrence, then subject a patient colonoscopy for every 1 to 3 years. If there is a recurrence in colonoscopy, one can consider addition of an immunomodulator or an anti-TNF. While in a low or moderate group, we have to start a 6-mercaptopurine or a azathioprine with a antibiotic addition if there is an abscess formation. And after this, we have to consider the colonoscopy after 6 months to 1 year. While in a high risk group, there is an addition of anti-TNF medication. And after that, we have to do a colonoscopy 6 months to 1 year post-op. If there is no recurrence, same, consider colonoscopy every 1 to 3 years. If there is an recurrence, increase the dose or dose with the duration of anti-TNF or other biologics. Last few slides, post-operative management of Crohn's disease. It is estimated that approximately 30% of patients who requires surgery for Crohn's disease will experience symptomatic recurrence within 3 years and as high as 60% within 10 years. Endoscopic findings that indicate recurrence include small aphthous ulcer, deep linear ulcer, mucosal inflammation, fistulae or stricture. This varying degree of endoscopic disease activity may be seen within 3 months of surgery in more than 70% of patients. The most common site of recurrence is the surgical anastomosis, especially the proximal site of the anastomosis. The cause for recurrence at this location is thought to be related to luminal contents, especially the intestinal flora. Endoscopic recurrence precedes clinical recurrence, and the severity of endoscopic findings predicts the risk of clinical recurrence. Now, this is the endoscopic score. I0, it's a no lesion, which corresponds to less than 10% of the clinical recurrence. I1 is less than 5 number of aphthous lesion, which correspond to 10% of clinical reasons. I2 is more than 5 lesions, which approximate correspond to 20% of the clinical recurrence. I3 is a diffuse aphthal ileitis with diffusely inflamed mucosa, which is seen in this picture, which corresponds to clinical recurrence rate of 50 to 100%. While I4, which is a diffuse inflammation with already large ulcers, nodules, or narrowing, which corresponds with this picture, which corresponds to the 50 to 100% of the clinical recurrence. Fistulas are a frequent, to summarize, fistulas are a frequent manifestation of Crohn's disease and can result in significant morbidity and often lead to the need for surgical intervention. Historically, it has been more difficult to obtain complete fistula closure in patients with perineal Crohn's disease. The advent of anti-TNF alpha agents and the use of more accurate imaging modalities such as MRI and rectal US has greatly enhanced the ability to manage visualizing Crohn's disease. A combined medical and surgical approach is usually the best option for most patients. Post-operative Crohn's disease recurrence is common. Several factors such as smoking stressors, continuing smoking, active smoking, then disease phenotype, type of surgical anastomosis, and endoscopic disease activity have been associated with the risk of recurrence. Patients with a high probability of recurrence should receive anti-TNF therapy. Those with less severe disease, azathioprine with or without metronidazole, and those at low risk, no medical treatment. Regardless of post-operative treatment, a colonoscopy within 1 year of surgery is the only definitive way to detect early Crohn's disease recurrence. So to summarize, Crohn's disease remains a complex disease process with many different manifestations in the colon, rectum, and anus. Although advances in medical therapy continue to evolve and change the way that patients are treated, surgeons still play a major role in disease management. Because of its recurring nature, surgeon must adhere to the dictums of dealing with the complications of the disease versus aiming for cure, and should focus more on maximization of patient functional outcome while minimizing the complications. Thank you.
Thank you, Dr.
Session
Ramteke, sir. Sir, with the increasing burden of the inflammatory bowel disease or the population with inflammatory bowel disease, especially in our areas or in developing countries like India, this presentation has surely helped us. Yes, the improving medical management, the screening modalities, as well as the developments that you rightly mentioned, they shall surely help us in our near future, sir. Thank you, sir. Now I would like to invite Dr. Suresh Chandak, sir. Sir is a senior faculty.
Hello, Dr.
And
Harshal, it was nice presentation. Hello.
Good afternoon, sir.
Hello.
Sir, Ramteke sir, nice presentation.
It was
Thank
nice
you, sir.
presentation.
It is quite
thank you for enlightening us.
extensive
Thank
one
you.
because it's a quite a
No, but
large
you have
topic,
taken,
so I have to concise it.
No, but you have taken much efforts to prepare these
Yes.
slides.
Thank you,
Thank you,
sir.
Harshal. Thank you.
Now I would like to invite Dr. Suresh Chandak, sir. Sir is a senior faculty and professor at JNMC Varda in Department of Surgery. Sir has always been encouraging us to read into new topics and look after all the recent and management skills of the recent topics. I would request sir to start with his presentation. Sir, your screen is visible.
Hello.
Yes. Yes, sir.
Am I audible?
Yes, sir, you're audible, sir.
Yeah. Thank you very much for time words. No, I will be discussing. So there is some noise there. What is
Rare
it?
case time meeting. बहुत ही rare case.
मेरा ऑडियो कहाँ है? कहाँ है? One.
We are just having some technical glitch with the internet connection. I
No problem.
apologize
No
for the
problem.
same.
Take your time.
Sir will be. Yes, sir.
Okay. Now I will be talking on colitis, which is one of the inflammatory disease, and it's common phenomenon nowadays. We are coming across such type of patients in day-to-day practice. Ulcerative colitis is a common disease. Otherwise, nowadays we are coming across in day-to-day practice. It is one of the inflammatory condition of the rectum and colon of unknown etiology, and there are some predisposing factors like stress, westernized diet, autoimmune factor, familial tendency, and allergic factors. What is there? Some technical failure is there. 1 minute. Stress factor, westernized diet, autoimmune factor, familial tendency, and there are some allergic factors. Disease commonly starts in the rectum and spreads proximally to the colon, and often into the ileum, and that leads to backwash, ileitis, and that is 5% incidence. Some technical failure, please wait. Enter, I have to put enter.
We can now see your screen, sir.
Oh, okay. Now, before going to the pathology, medical management, and surgical management, I will make you some familiar about this anatomy of the colon. The colon is a large bowel which is around 1.5 centimeter long and has got different parts, cecum, even appendix is also part of large colon, transverse colon, descending colon, and sigmoid colon. And later on, that's the rectum. The wall of the colon is composed of 4 layers: mucosa, submucosa, muscularis propria, otherwise called muscula externa, inner circular muscle layer, outer longicular muscle layer, and there is a serosa, that is visceral peritoneum, and which is concentrated in 3 separate longitudinal strips, which is called tinea coli. So tinea coli, appendices epilochi, and hostria, which form the circulation with the features of large colon. But if you see the rectum, you will not have these all hostria, circulations, and tinea coli. Ileocecal valve serve as a sphincter to prevent the back reflux to terminal ileum. Now we go to the blood supply, because when you are doing colectomy or proctocolectomy, you should know the blood supply. Ileocolic, right colic, middle colic, these are the main branches of the superior mesenteric artery. And then on the left side, left colic, sigmoid superior rectal arteries, which are the branches of inferior mesenteric artery, supplying descending and sigmoid column. Anastomotic arcade between the branches of superior and inferior mesenteric arteries is called arc of Revlon. The venous drainage, superior mesenteric vein and inferior mesenteric vein, which drains into portal vein. Now, lymphatic drainage, though it is not a malignant disease which I am dealing with ulcerative colitis, but one should know the lymphatic drainage. In briefly, I can tell you the mucosa contains no lymphatic channels, no mucosal cancer rarely metastasis. So mucosal cancers rarely metastasize. Now I written here EP. So most of the postgraduate students are attending this one. If we ask them question about what is the lymphatic drainage of this large coral, you just remember this mnemonic EPIC: epicolic, paracolic, intermediate, and central. Central is otherwise called principal. The nerve supply, again, you should know the nerve supply. It is controlled by the autonomic nervous system, parasympathetic by vagus, pelvic nerve, sympathetic by superior and inferior mesenteric ganglion. The effect of meal on colonic activity is termed as gastrocolonic reflex, again, which is very common symptom in sometimes in OPD patients. Surgical anatomy of the rectum, it is a distal portion of the large gut placed between the sigmoid colon and anal canal in front of the last 3 pieces of the sacrum and coccyx. 3 cardinal features of large intestine: circulation, appendix epilochi, and tinea. These are absent in the rectum. By peritoneum on front and side, mid thumb only on the front, and lower third is on the intraperitoneum. The rectum is full covered by the puborectal sling, which forms the anorectal sling, which is more responsible for this rectal incontinence, rectal continence. Rectum is supplied by rich network of vessels that originates from superior middle rectal artery and median sacral artery, which directly a branch of abdominal aorta. Lymphatic drainage from upper half of the rectum is to the inferior mesenteric nodes, from lower half to the internal iliac nodes. Nerve supply, it is innervated by autonomic nervous system, sympathetic, parasympathetic. Sympathetic is motor to sphincter and inhibitory to musculature. Parasympathetic is more to musculature and inhibitory to the sphincter. The sensation of distension is carried to the parasympathetic and pain sensation is carried by both. So when you get urge of defecation, so this plays a main role. Now, westernized diet, consumption of red meat, non-vegetarian diet, low fiber diet, these are all predisposing factors for the development of ulcerative colitis. Now, defective mucin production in the colonic mucosa and mucosal immunological reaction is also one of the predisposing factors. Autoimmune factors, cytotoxic T lymphocytes against colonic epithelial cells and presence of anticolon antibodies. Allergy to the milk, that is especially the cow milk, that's why we avoid or we tell the patient not to consume the cow milk, because there may be remission following this cow milk, and other dietary factors also plays main role. Excessive reactive oxidative metabolism in ulcerative colitis. There are psychological impact, stress, lifestyle, and personality disorder, which also plays the main role in the development of ulcerative colitis. Now, if you see the pathogenesis, what is pathogenesis? How it develops? So, minute ulcer, that is called pinpoint ulcers, very common feature, which I'll show you the endoscopic view in the next diagram. With proctitis and colitis, these ulcers extend into the deeper layer, spasm of bowel, followed by stricture of colon, permanently contracted colon, that is pipe stem colon, and in between ulcers, epithelial thickening occurs, which appears like polyps, and that is called pseudopolyps. So for remembering how to remember these 5 or 4 P's, one is pinpoint ulcer, second is proctitis, which involves the rectum mainly, and pipe stem colon, pseudopolyposis. So these are the 4 things, and you can have pus cells under the mucosa. And you can see the pseudopolyposis, this is the dissected segment in this ulcerative colitis, and you can see the other picture of Crohn's disease. So ulcerative colitis and Crohn's disease go hand in hand. Diagnosis of ulcerative colitis. There is some noise here. Please, I will request the viewers, please mute it. Okay. Now you can see the resected segment of the large colon. You can see the appendix, ascending colon, transverse colon, hepatic flexure, splenic flexure, and descending and sigmoid. And other picture you can see there is a creeping fat in Crohn's disease. I'll be differentiating both in next slide. Now it is a disease confined to the mucosa and submucosa. So mucosa and submucosa is the victim. Okay. And if you see the Crohn's disease, it is a transmural disease from mucosa to serosa. But in here, only mucosa and submucosa is involved. I will come to the treatment part where we do only mucosectomy and we maintain the lumen of the colon. I'll come to the surgical part when I come to there. There is no bowel wall thickening and no granulation formation. If you see the chronic, if the definition of Crohn's disease, it is a non-causating transmural disease and granulomatous disease. But here, no bowel wall thickening, no granuloma formation, and there are no skip lesions, and only rectum is involved in this ulcerative colitis. Distal bowel is involved to begin with, and then spreads proximally, and distal involvement is more severe. Entire colon, including cecum and appendix, may be involved. I will tell my PGs here. Most of the times I ask, appendix is a part of small intestine or large intestine. They always tell small intestine. For your knowledge, appendix is formed by the three tinea coli, and that is a part of the this large colon. Because when you do appendicectomy, we take out the small intestine and we do not bother about the large intestine, and we say that it is a part of small intestine. No, it is not like that. Appendix is a part of large intestine. Only rectum involvement is proctatitis occurs in 25% cases. Such patients still have 5% risk of developing rectal malignancy or cancer. In 15% cases, it is left-sided ulcerative colitis in presentation. Bloody diarrhea, you can have frank blood per rectum or per annum, then malnutrition and complications like toxic megacolon. I'll come to the presentation of all these ulcerative colitis, acute and chronic. So acute form will be toxic and perforation, and sometimes it may be obstruction, and carcinoma is a delayed complication. Pseudopolyposis or pseudopolyps are the inflammatory in nature. Absence of normal mucosa between this pseudopolyp is important to differentiate it from neoplastic polyps, that is adenomatous polyps. Intense inflammation in the mucosa and submucosa with typical features: multiple keratosis, sparing of deeper layer of the colonic wall, inflammatory pseudopolyps, multiple pinpoint ulcers, increase in substance of P containing nerve fibers, liquid hyperplasia in mucosa and submucosa, and presence of anti-neutrophil cytoplasmic antibodies with perinuclear staining pattern in around 85 to 90%. And there are decreased goblet cell mucins. Now, when you talk about ulcerative colitis and Crohn's, you have to talk about Crohn's disease. And when you talk about Crohn's disease, you have to talk about intestinal tuberculosis. So differential diagnosis, if you see, my previous colleague, Dr. Amteke sir, has elaborated nicely about the Crohn's disease. But still, without Crohn's disease comparison, ulcerative colitis is not complete. So just few points I will tell about this in comparison point of view. So Crohn's disease is transmural and ulcerative is mucosa and submucosa. Here skip lesions are there. There are no skip lesions here. It is the granulomatous, it is non-granulomatous, it is cageting, it is non-cageting here. And if you compare to tuberculosis, that is cageting. And stricture and fistula is very common in Crohn's disease because it involves the complete wall, and narrowing is very common in ulcerative colitis. And ulcerative colitis, you will not have a lump presentation or lump in abdomen presentation, but in Crohn's disease, you will have presentation, the right iliac fossa mass, and that may mimic sometimes intestinal tuberculosis or ileocecal tuberculosis. They say, our teacher used to say, if you are dealing with right iliac fossa mass in UK or England, first diagnosis should be Crohn's and second diagnosis should be tuberculosis. But the same patient with the same lump, if it is in India, to make the first diagnosis intestinal tuberculosis or ileocecal tuberculosis, and second diagnosis you keep as a Crohn's disease. So this is the incidence wise. So as per geographical incidence, bleeding is very common in Crohn's disease, even ulcerative colitis. But if you see comparatively, bleeding is more in ulcerative colitis. Crohn's disease mimic appendicitis, and ulcerative colitis will not mimic like appendicitis. So you should keep your eyes open to make any differential diagnosis, and you should be ready when you open the abdomen and if you found out if there is a chronic Crohn's disease, what you should do and what you should not do is what you should not do appendicectomy if you have clinical suspicion of Crohn's disease. This is especially for my undergraduate and postgraduate, those who are attending. Now you can see this endoscopic view. Now, why I specially showed the endoscopic view? Without endoscopy, you cannot take the biopsy. Blind biopsy has nowadays no role. So either you take what is called video assisted flexible colonoscope, video assisted flexible sigmoidoscope. You have got rigid sigmoidoscope. In our days, we used to do sigmoidoscopy, but you cannot go complete survey till ileocecal wall. Sometimes you can insert your colonoscope in the terminal ileum. Now, what I want to say you here, Actually, it is a disease treated by the physician and medical gastroenterologist. When they raise their hand, they cannot do anything. Then they send to the surgeon. What the surgeon will do in an advanced matter or conventional manner, he will treat it. Now you can see the pinpoint ulcers in this colonoscopic view. That is pinpoint ulcer. Already I told you there are 4 or 5 P's. First P is proctitis. Second is pinpoint ulcer, pseudopolyposis. Then you can have pipe stem colon, and you can have pustules also. Now you can see this other this endoscopic view or colonoscopy view of this Crohn's disease. There is no specific pinpoint ulcer, so spreading form of this mucosa you can see here. Now clinical feature is very important. One should make the clinical diagnosis. Clinical diagnosis, again, patient usually comes to you as an emergency, or sometimes it can come as an elective patient. You have to make the diagnosis. If you feel like bloody diarrhea, perforation, obstruction, so you should not waste your time in doing all investigations. So clinical suspicion is very important, and even sending for colonoscopy and all these things you can explore and deal accordingly. If you feel it is a large colon or toxic megacolon, you can straightway go for, without biopsy, you can go for what is that called proctocolectomy. The disease usually begins in the rectum as a proctitis, later becomes left to right, and it comes proctocolitis. More common in females, begins in the 3rd decade to 4th decade. Watery diarrhea, mucus blood stain discharge for rectum. Usually make the diagnosis malignancy, but it is a benign disease, but which beware is malignant. Patient can die, which the malignancy patient may not die on 1 month or 2 months, he will die after 2 years, 2-3 months, but it is an emergency. Colicky pain, spasm, and tenesmus at lavatory site. Now, again, my PGs are attending this CME. What is lavatory sign? You will not be knowing, but I will tell you what is lavatory sign. Lavatory sign, the patient gets the urge to defecate, and he will not have any defecation because of perirectal spasm or perirectal any inflammatory condition or any mucosal inflammation, and the patient will get urge to pass a motion without defecation. So that is lavatory sign. And same in other words, you can tell tenesmus. For tenesmus, you can have sometimes fecal matter or not. So you can say tenesmus is also called lavatory sign. Decreased appetite and loss of weight, these are all constituent symptoms of malignancy also, even tuberculosis also, but these are all constituent symptoms. These are not specific symptoms of this disease. Relapses and remissions at regular interval. This is a very common phenomena in ulcerative colitis, because patient is on drug, then there are remission. When you stop the drug and he changes the lifestyle, he goes for whatever diet he habits, then there is a relapses. So when treatment part comes, you have to sometimes, if you cannot treat the complete disease, you have to control or do the remissions and prevent the relapses. Now there are 2 types of presentation, that is acute, that is fulminant type, and second is chronic. So fulminant type is most dangerous. Surgeon should be ready to deal it, to treat it vigorously. It is a severe form, continuous diarrhea, passage of blood. There is very frank blood. It is not like coffee colored blood or all this cherry colored blood. It is very frank blood, because it is a frank blood coming from the rectum and colon itself. Mucus and pus, patient is ill and dehydrated, tongue is coated, and sometimes you can have hypotension. Patients sometimes land up in a shock. It mimics fulminant amoebic colitis, severe typhoid, dysentery. Now, amoebic colitis, if I want to just utter this word here, there is one more sign that is called MAN, which is nothing but the mirror image of what is that called Blackburn's point. So in the left side, there is a Manson-Burr sign. On the right side, there is a what is that called this Blackburn's point. Fever, hypokalemia, acidosis, dehydration, and shock. These are the symptoms serially you can have, and sometimes patient land up in a death. Abdominal distension occurs when there is an acute dilatation of this colon, especially the transverse colon. If you see the lumen of the transverse colon is around 2 to 3 centimeter, but if it increases more than 6 centimeter, which you can see even plain X-ray abdomen, I will show you that slide. So transverse colon may occur when the diameter of transverse colon is more than 6 centimeter, and when you see and percuss clinically on the epigastrium, you will have tympanic node and it mimics like a sigmoid volvulus. It has a high mortality, requires emergency surgery, that is either colostomy, that is diversion colostomy, maybe permanent or maybe temporary, with resection, without resection. So this you can do it, depend if it's obstruction. If there is a bleeding, you have to subject the patient for total proctology and resection with ileostomy, or otherwise you can restore the continuity by ileoanal anastomosis, that is more physiological than other thing. So later ileoanal anastomosis, here colon is like wet blotting paper. So when you do management of surgically, that I'll tell you, you have to try to preserve maximum anatomy, maximum physiology, and deal the disease, treat the disease. Now chronic type, last for months to years with diarrhea, blood loss, anemia, invalidism, abdominal discomfort, pain, loss of weight, loss of appetite. So these patients can be managed by lifestyle or other psychological counseling. Severe malnutrition by total parental nutrition. Now investigation part. Now once you clinical diagnosis you make it, I will go to other slide. Before going to investigation, you should have some differential diagnosis in your mind. 1 minute. Now this is differential diagnosis, then I'll reverse it. Now always keep clinical diagnosis, differential diagnosis. The first is Crohn's disease, ischemic colitis, tuberculosis, irritable bowel syndrome, amoebic colitis. There is a list of it. Even carcinoma colon can present like this. Now investigation, barium enema. Now we are here, now get tertiary centers, all advanced investigations are available, but plain X-ray abdomen you can go for. Now any acute abdomen, I will tell my juniors and whosoever, don't send this patient directly for ultrasound. Get this plain X-ray abdomen. So many things you can see in a X-ray abdomen, including perforation, calcification, even pancreatitis you can diagnose, or in uric acid, sometimes gallstones are visible, or sometimes you can see the indirect features of appendicitis, that is scoliosis. So plain X-ray abdomen is very, very important. It doesn't take any time or any cost. But barium enema is a contrast study. Nowadays it is obsolete, but still, if you want to do some clinical study or some postgraduate research, the barium enema, yes, you can have what is that called loss of oscillations, narrow contracted movement, that is pipe stain, colon, stem pipe colon or hose pipe, mucosal changes, pseudopolyps. So it is avoided in fulminant cases. So when there is acute emergency, fulminant, don't do barium enema, because if you do barium enema, the localized what is colitis or proctitis may become generalized or total proctocolitis. So avoid barium enema. But plain X-ray, yes, we can do without harm. Now sigmoidoscopy and biopsy. Instead of going sigmoidoscopy, I will go for colonoscopy, because sigmoidoscopy is limited and better is go for colonoscopy, video assisted colonoscopy. The total survey of the colon, including what is that called backwash ileitis, can be seen by this colonoscopy. And not only that, biopsy should be taken in a suspected area. Even you have got an ulcer, minute ulcer, which is more diagnostic, you can take the biopsy. But when there is a suspicious lesion wherever in the colon, you take multiple biopsies. So due to very high incidence of malignant transformation in ulcerative colitis, that is 20%, multiple biopsies should be taken from the suspected area of the colon. And don't bother up that if you take the biopsy that it will perforate, and not like that, because it is a lesion of mucosa and submucosa, that is sufficient. So you can take mucosa and submucosa, and beyond that there is a musculosa. The chances of perforation, iatrogenic perforation, is very, very rare, and with the expertise hand, it is very rare. So risk increases with the age of the patient and duration of the disease. So age in the sense, older the age, the risk is more, and duration of the disease, if you see the duration is the more, the chances of transformation to malignancy is more. Now, pale X-ray already I told you. I'll go to next slide. This one. Now you can see the plain X-ray here. Now plain X-ray, the middle X-ray, you can see the transverse colon. The diameter of the colon is increased. It's more than 6 centimeters. Even with naked eye, unaided eye, you can see this transverse colon that is transverse. But same feature you can get in a pancreatitis, but that is a actually sentinel loop of jejunum. But in a transverse colon, you cannot. You will see the lumen is enlarged. Now this barium enema, you can see in the first plane, you can see the loss of oscillations here. So this is the descending colon. Loss of oscillation is already there in the rectum, but in a descending colon or hepatic flexure, there is a loss of oscillation. So this is you can make the diagnosis that it could be a that is ulcerative colitis. But ulcerative colitis without biopsy, without histological proof, you cannot proceed because it is a benign disease. One form is other disease. Removing complete colon, you should have some histopathological diagnosis in the, to the patient. Emergency is different, fulminant colon is different, or chronic colon is different. So always to have a biopsy proof, provided patient is comfortable in a chronic stage, you can go for barium enema, CT scan, so on and so on. But you should take endoscopic biopsy or colonoscopic biopsy, wait for histopathology, take the patient electively, and when you do or when you design the ileostomy or colostomy, whatever it may be, you should design properly. So elective surgery has got good outcome. Now you can see this resected specimen here. This resected specimen, you can see there are lots of oscillations. So you can see it. I don't want to discuss in detail. Go back, go back, go back, go back, go back, go back. Now I was on this slide, obstruction, toxic megacolon purpose. This is the ideal real emergency. Nowadays, there is no role of midnight surgery. You can treat this patient, you will diagnose the obstruction, even you diagnose the megacolon, even you diagnose the perforation, you hydrate, resuscitate the patient, take the routine OT as a routine OT. Though it is a emergency, but take it in a routine procedure, you can treat electively. But if there is a bleeding, you should not wait for morning elective surgery. You do it in the midnight. And naturally, you have to support by blood transfusion and whatever perfusion and resuscitate it, and C-reactive protein will be very high in acute phase. So this is just side by diagnostic. You can go for C-reactive protein, but even if you don't have C-reactive protein in hand report, you can straightway go for the surgery. Differential diagnosis already I discussed. So you see my list, there is no ileocecal tuberculosis. Always keep ileocecal tuberculosis as the differential diagnosis. Now you already I mentioned and described all these things. Now pseudopolyposis, malignancy. Now complications are pertaining to gastrointestinal tract. Instead of gastro, I will tell intestinal. Okay, so GIT, so rather intestinal. Stomach is not involved in ulcerative colitis. So intestinal and extra-intestinal. So pseudopolyposis, malignancy, stricture formation, toxic megacolon, massive hemorrhage, that is only 1% cases. So that's why emergency surgery is rarely done in ulcerative colitis. Yes, fistula in nano, 20% cases. Usually it is high. From the rectum. And perforation, 10 to 20% cases, you can have perforation. Now extra-intestinal, severe malnutrition, liver cirrhosis, skin lesions, pyoderma, erythema nodosum. Most of the times, the patients are referred from dermatology unit to us, and they will have some presentation. And when patient comes to us, then we diagnose something wrong to the colon. Arthritis, the patient will land up in any department, orthopedics, medicine, dermatology, and even sometimes it will land up in ophthalmology, OPD, like iritis. sclerosing colitis, especially present like obstructive jaundice, which is one of the cause, and carcinoma of the bile duct. So multimodality is needed here. Now, general consideration. Naturally, any disease patient, first is your clinical diagnosis. If time permits, go for some imaging studies, go for histopathological study. If there is no time, if time doesn't permit, then you just resuscitate. Resuscitation, everybody knows, correction of anemia, cumulative electrolyte balance, total parenteral nutrition, because outcome will be good. If you have got, if you treated the hypoproteinemia properly, in any major surgery, total parenteral nutrition, one must adopt this procedure. And sedatives and tranquilizers is very important, because sometimes these patients are psychologically upsetted and patient be sometimes agitated, and you should have psychological counseling. Now, active disease, drugs are used to induce remission. Remission in the sense, whatever disease is there, you control it. Once you control it, so that's why acute phase you turn into chronic otherwise. So remission is control, that some drugs should be given for maintenance therapy and to prevent relapses. Relapses, in other words, you can say recurrence of the same symptom. Now there are some drugs which I don't want to tell you here. Even I do not use these drugs. I always take help from my physician colleague or my medical gastroenterologist. So please make me sorry here. So only sulfasalazine I will tell you here, and I think you should not bother about these drugs also, as it being the CME of the surgeons. Again, high ASA, steroids, oral prednisolone, even prednisolone can be given, or in the enema form it can be given, or intravenous hydrocortisone can be given. So in different routes, either oral drugs, either intravenous drug, or intracolonic, that is enema, can be given of the hydrocortisone. And there are other drugs, even it is very difficult for me to pronounce this drug, but still I pronounce it. Bude so nice. First time I read this. Now, immunomodulator, azathioprine, cis-mercaptopurine, my colleague described all these things, cyclosporine, mebeverine hydrochloride, tegaserod, other drugs are there. But all these drugs are for some definitive management, but for symptomatic treatment, sucralfate, short-chain fatty acids, probiotics, antidiarrheal drugs, dibenoxolate, loperamide, because you have to control the diarrhea. So for these, even analgesic, antispasmodic to be given, sometimes sedatives, tranquilizers, these drugs can be given to this patient. Now, what to avoid? Avoid coffee. Coffee to be avoided. Today I avoided the coffee, but not like that. Coffee, milk products, fibers, and fruits. This to be avoided. I do not know what is the pathogenesis behind it, but they says that coffee, milk products, and fibers, fruits. Now, again, I tell you, fiber is written in the book. I have got a doubt about myself, how I can tell fibers, because if you take a high fiber diet, you will not have ulcerative colitis. Those who are non-fiber diet, they will have ulcerative colitis. So please make me sorry here. Now treatment. Now the surgeon role comes. Now our physician colleague or medical gastroenterologist raises his hand. I do not do anything. I cannot do anything. Please, Dr. Chanda, come and do something. Then surgeon comes, he wears the gloves and gowns and all these things, and he will prepare. He will tell his postgraduate student, do and prepare all these things. Now, what is the concept of surgical? Now, what is it acute or chronic? If it is acute, don't bother about this. You save the patient. It is a life-threatening thing. So don't bother about the physiology, anatomy, anything. What you do, you stop the bleeding. You control the whatever obstruction, or treat the obstruction, or treat the perforation. Treat the perforation in the sense you take out the colon, do diverting colostomy like that. So try to preserve anatomy, try to use the physiology. What is mean by physiology? Restore intestinal continuity with continuous, very important, continuous. So ileostomy may be continent, ileostomy with incontinent. So that is Cox ileostomy, that I'll come to that one. Now, I have not shown any video here. I don't want to waste your time and my time, and you can read nicely from the books. It is called restorative proctocolectomy. What is meant by restorative? Because fecal matter which comes to the sigmoid colon, when you remove the sigmoid colon and rectum, you have to create the pouch. So colon has got a capacity to absorb maximum water from our body, and that's why you develop constipation. So always ask the patient to take plenty of oral fluids to treat the constipation. One, and secondly, you should have pouch. Just like when you do gastrectomy, you also create pouch. When you are doing some colectomy or proctocolectomy, you have to create the different pouches, either J manual, S manual, or W manual. I'll tell you this one. 1 minute. This way, you can see this one. So this J manual, Y manual, you can see the three switches are lined, but they are actually interconnected lumens. So if you see after that, there will be a single lumen from descending colon and it will go to the anal. Right. This one. So it is called restorative. So you have to create the pouch. Very important. Anal sphincter, yes, you have to try to preserve. So anal anastomosis is very and good physiological, but when you cannot preserve it, but nowadays you can preserve it. We have got staplers. You can per annum you can put the end-to-end staplers, and you can do even malignancy. APR nowadays sometimes you can avoid even malignancy because of advancement of these staplers. Anal sphincter complex is preserved. 30 centimeter of ileal pouch is created, either hand sewn or by stapler. Created ileal pouch reservoir is anastomos just above the anal canal using end-to-end stapler, and diameter of the pouch should be twice the diameter of the ileum. Now, how to create this? Now, again, when suppose you are doing ileoanal anastomosis, the lumen of the colon is larger than the lumen of the ileum. So, what you do? You just increase the lumen of the ileum. Now, how will you? That is called chitil cut, or otherwise called fish mouth cut, and you suture it, and so that this transverse colon lumen and ileum terminal ileum or whatever the distal end, you can proximal end and distal end of this colon and ileum. You can do anastomosis, and transient time will decrease. Obstruction, yes, you have to treat the obstruction. It is not easy to treat obstruction, colonic obstruction. It is not simple like perforation of the small intestine. So obstruction you have to treat either side to side anastomosis, but suppose you have got definitive diagnosis, clinical diagnosis, it is a ulcerative colitis, take out complete colon, you can treat the obstruction by ileoanal anastomosis. Diarrhea, again, surgery, pouchitis, leak sepsis, and incontinence. These are all complications, but you can prevent all these complications by taking specific measures when doing surgery. Then, if you do special elective surgery, these complications can be avoided or can be minimized. Total proctology in ileostomy. Just this is the only operation you should know. Even any question you get it in your postgraduate or undergraduate question, and any student simply writing total proctology with ileostomy, whosoever the examiner is happy. And second is proctology in non-continent ileostomy or continent ileostomy. These two operations you should know it. Please make me sorry, I have not shown any video, I have not shown any diagrams, but these two diagnoses are two operations you should know. Permanent, it can usually permanent. Usually, ileostomy is a permanent, which is a continent Cox ileostomy, which is created. Now, what is meant by continent and incontinent? Incontinent means throughout your day, you will have the fecal matter, which mostly liquid from the ileostomy, and then your bag will fill. But Cox ileostomy is under your control. Under your control means not under your control of your brain or sympathetic. It is under control of your finger. You put your finger in that ileostomy, and suddenly the fecal matter will come. So that's brief about continent Cox ileostomy. Some wall is created. So once that wall is open, by just putting in the finger, and you can have this continent ileostomy. But again, it needs expertise. With one-way wall is done. It is used at present only in revision surgery when needed after restorative proctology. Total proctology with any non-continent ileostomy, it is now reserved only for ulcerative colitis, complicated with carcinoma of the ileostomy site should be marked if you are really doing elective surgery. So either standing posture or sitting posture, because it should be designed whether it's ileostomy or colostomy, because it should not, the whatever bag, colostomy bag, when you mount, it should not, it should avoid the bony prominences and you should avoid the main scar or umbilical scar. So very important, you should design prior to surgery, provided it is elective surgery. Stoma should be within the right rectus abdominis. Again, I'll tell you, before creating stoma, first do counseling with the stoma therapist. Now these are the pouches which already I've shown you. This is the diagrammatic and you can see the pouch is created. The colon lumen of the colon is increased just like a rectum or sigmoid colon. Treatment surgeries, total colectomy with ileoanal rhinorectal anastomosis or total colectomy with rectal mucosectomy. Now rectal mucosa actually is the victim. So mucosa you can remove, or naturally mucosa and submucosa, and this muscular layer and serosal layer you can maintain it, and you can do anastomosis directly to the anum or anus. So ileoanal anastomosis, or you can do what is that called, ileorectal anastomosis by doing mucosectomy. Now take home message. Now I will tell take hostel message rather than take home message, because most of the PG students are attending. Although it is a benign disease, yes, it is a benign disease, but its behavior is malignant. Patient can die if you are not timely treated this patient. So it is sometimes surgical emergency. So all malignancy, all adenocarcinoma are malignancies, but their behavior may not be malignant sometimes. But benign disease can have a malignant behavior, so that means you immediate surgery. Just like a disease, malignant headache disease, it is not malignant, but behavior is malignant. So like that. So moreover, it is a potentially malignant. So you are taking out the disease and complete colon. Na rahega bas na basuri. Sab nikal do pura. ठीक है. Evaluate completely, treat vigorously. Vigorously in the sense not like that, go to the gym and do everything in it. Surgeon do vigorously in the sense he is ready to do anything and he should do immediately. And colonoscopy with multiple biopsies, a suspected lesion. Again, I want to repeat here, my gastroenterologist colleague, even colonoscopy is done by surgeons, even medical persons or medical gastroenterologists, but in our center, all are doing. So colonoscopy, if there is a clinical suspicion of ulcerative colitis, go for multiple biopsies, let it be negative, but you are happy. In suppose you get some synchronous lesion somewhere like that, which is a pre-malignant condition, then you can get it and you can treat accordingly. Surgical intervention, failure of medical treatment beyond 7 days, call the surgeon and get it done, whatever you want to do it. The surgeon starts where and when our physician can stop. Thank you very much for patient listening. Thank you very much. Any questions you can ask me directly.
Thank you so much, sir. As I mentioned earlier, inflammatory bowel disease is increasing. The burden of the disease is increasing. For us who are at the beginning of our careers, this presentation was an important tool in knowing the exact pathology, the exact diagnostic modalities, screening modalities, as well as the management protocols. As we know that this is a very lengthy and a very broad topic. Sir, thank you so much for summarizing it so well for us, sir. Thank you so much, sir.
Candid sir, thank you for enlightening us on this topic, sir. It was very well described. Thank you, sir.
Now, moving forward, it gives me immense pleasure in welcoming back Dr. Meenakshi Ella ma'am, who is now additional professor at AIMS Vijayawada, Mangalgiri. Ma'am is also our former HOD. Ma'am, it has been immense pleasure learning from you. I cannot tell you how much we female surgeons have always adored you with you around us. and teaching us every small thing. And every time we watched you operate in the OT, it really makes me happy to welcome you, ma'am. Ma'am, we are making you the host. Kindly share the screen, ma'am.
Start video. This I will have to click.
Done. Now
Okay. You just close it.
Madam, good morning. Good afternoon.
Good afternoon, sir.
Long time no see.
Yes. Nice to hear from you, sir.
Your
Nice
body is there, but your Atma is here.
lecture that you have delivered.
No, your body is there, but your Atma is here.
Sir, difficult for me to this. Hello.
No, your body is there, your Atma is here.
Oh, yes. Physically, I am here. Mentally, I am at Sahangi.
Yeah,
Yes.
Yeah.
Thank you, Dr. Lamture sir, for giving me this opportunity to deliver a very important lecture on a very important topic, that is rectal prolapse. Because when the patient comes to the OPD, then there are so many questions which are in our mind, how to go ahead with such cases. And I think at the end of this talk, all the things should get clear. Before directly going to the topic of this rectal prolapse, I think it is very important for us to know about the anatomy of the rectum. So as everybody knows, that rectum is approximately 12 to 15 centimeter in length, and which is marked by the fusion of the tinea coli into a completely this circumferential muscular layer up to the anal canal. Now this rectum transitions from beginning intraperitoneal to being completely extraperitoneal. It is almost 6 to 8 centimeter from this anus. So this part is intraperitoneal, and rest this terminal 6 to 8 centimeter from the anus, it is the extraperitoneal, and it is very important for us to understand when we will deal with the concept of what is meant by rectal prolapse. And this rectum is fixed posteriorly and laterally by the Walden's fascia and the lateral stalks respectively. Now, if you consider in male patients, this rectum is fixed to this Denon-Valiers fascia, a fold of two posteriorly from this prostate and the seminal vesicle. So this relation is very important to understand in case of males. And when we consider in female patients, the peritoneal cavity descends to the pouch of Douglas, and its most dependent point being adjacent to the cervix anteriorly and mid rectum posteriorly. So this anatomical relation to understand is very important. So this layer of Denon-Valiers fascia that separates the rectum from the anterior structures, and that forms the plane of dissection which must be sought after in the excision of the rectum, or when we will deal with the surgeries of the rectum. And laterally, this rectum is all the time is supported by the levator ani muscles. Now, as we have seen, what are the relationship of the rectum in case of male. So anteriorly, you will get the prostate gland, then seminal vesicles, vas deferens, ureters, and urinary bladder. And posteriorly, this very important is the sacrum and this fascia of Waldeur's, coccyx, and its muscles. Then levator ani muscles, median sacral vessels, and the roots of the sacral nerve plexus. Now, this posterior relation, why it is important to understand? Because when we will do the perineal or abdominal surgeries for this rectal prolapse, there is always a presacral venous plexus. There are high chances of injury to that plexus, and we have to keep above that plane. We should not expose that presacral plexus of veins, otherwise there can be torrential bleed, and your clean cut surgery may turn into a there can be a torrential bleeding, which may be many a times difficult to control. Then in case of females, the relations anteriorly you get a posterior vaginal wall, laterally intestinal loops, and the intraperitoneally the anteriorly you will get a posterior vaginal wall, upper uterus, fallopian tubes and ovaries, laterally pelvic wall, and posteriorly the relations are the same as you will get in a males. Then when you see the endoscopically, the rectum has 3 valves of Houston, and the middle of which corresponds to the anterior peritoneal reflection. So this anatomical understanding is also very important. Now, what is meant by dentate line? So it is the distal end of the rectum, and this line is clearly visible on the anoscopy, but histologically it is the junction between the columnar mucosa of the rectum and the transitional or the squamous mucosa of the anal canal. Now, again, this concept is very important to understand. At rest, how is the position of the rectum, and what is this anorectal angle? So, why this we won't get a fecal incontinence? Because it is because of this anorectal angle. Then continence because of this external anal sphincter, internal anal sphincter, and very important is this puborectalis sling, and the position of the rectum, how the lie of the rectum is also very important. And what happens during straining? It gets straightened up. This angle gets opened up, this anorectal angle, and there is a descent of the pelvic floor. So this understanding is also very important before going ahead actually for the concept of rectal prolapse. So this is the puborectalis sling which holds the rectum in position. And what is the attachment of this puborectalis muscle? That is important to understand. Now, what is meant by rectal prolapse basically? So it is nothing but it is an intussusception of the rectum, which may be categorized as occult, that is internal. It can be mucosal, or it can be complete rectal prolapse. Now, there are 3 types of rectal prolapse. The rectal intussusception above the anal canal, that is internal prolapse. It can be partial or incomplete, that is known as mucosal rectal prolapse, and it is complete, that is full thickness rectal prolapse through the anus, and which is the commonest variety that we are getting. Now, depending upon the degree, first degree means it is high or concealed, or which is invisible. Second degree, which is externally visible on straining, and the sulcus is evident between the rectal wall and the anal canal. And third degree means which is the complete prolapse, or which is externally visible. So the mucosal prolapse, now there is protrusion of this mucosa with the muscular layers of the rectum remaining in place. So there is only mucosal prolapse. Okay, the muscles are in place. So that is important to understand what is meant by mucosal prolapse. And what is in the complete prolapse or procedentia? There is a full thickness protrusion of the rectum through the anus and in a circumferential fold. So that is very important to understand between mucosal prolapse and a complete prolapse. So this is the complete prolapse, that is the procedentia. Now, what is the pathology of this rectal prolapse? So there is a protrusion of the rectum beyond the anus. Always there is a female preponderance, and the peak incidence you will get in the 6 to 7 decades of life. Now, the risk factors like chronic constipation, chronic diarrhea, patient may be, there are patients may be having mental retardation, and the female sex preponderance is always there. Then anatomic abnormalities are associated with this rectal prolapse, like loss of horizontal position of the rectum and its sacral attachment. We have already seen how it is attached, but when this horizontal position is lost and it becomes like a almost straightening of the rectum because of some anatomical variations, then there are chances of this rectal prolapse. Then patulous anal sphincter, that is the another associated anatomical abnormality. Then there can be diastasis of this levator ani muscle, that we have already seen how important this muscle is, and whenever there is diastasis, there can be chances of rectal prolapse. Then redundant rectosigmoid colon, it is very, very important to understand, because when we will deal with the management of this rectal prolapse, we should know beforehand whether there is it the reason for the rectal prolapse, because we have to manage this. We have to go ahead with excision of this redundant rectosigmoid. Then only the recurrence can be prevented. Then deep cul-de-sac. Okay, so this cul-de-sac, if it is deep, there are chances of rectal prolapse. Then the anatomical abnormalities which can be seen with the patients, like deep rectovaginal or rectovesical pouch, lax pelvic floor musculature, failure of the normal relaxation of the external sphincter, redundant sigmoid, and the pudendal nerve injury. Other factors like elongated mesorectum, perineal descent, herniation of the pelvic organs through the pelvic tunnel, and loss of support of the uterus and bladder. So everything matters when we consider this rectal prolapse. Now, what are the precipitating factors? So when we will take the history of the patient, we should always ask what can be the precipitating factors in that case, because unless and until we treat those factors before going for a definitive management, so which can be treatable, these precipitating factors, that we must understand before going definitive management for this rectal prolapse. Now, the advanced age is one of the factors, then which is that we cannot modify. Then long-term constipation, long-term diarrhea, that we have to treat before directly going ahead with the definitive surgery. Then long-term straining during defecation, pregnancy and stresses of the childbirth, then previous surgeries, cystic fibrosis, chronic obstructive pulmonary diseases, whooping cough, multiple sclerosis, and the paraplegia. These are some of the precipitating factors. Now, there are various theories which are put forth. What can be the etiology, or what can be the cause for this rectal prolapse? So the one, this Moskowitz theory, which came in 1912, is that rectal prolapse is nothing but it is a sliding hernia that protrudes through a defect in the pelvic floor. So if you can appreciate, so it is a sliding type of sliding hernia, as deep rectovaginal and the rectovesical pouch is the striking feature in most of the cases. So it is considered as a type of sliding hernia which leads to the rectal prolapse. Then Broden and Snellman theory, which put forth in 1968, that prolapse is a circumferential induced susception of the upper rectum and rectosigmoid colon. So if you can see this, so there can be induced susception. If you can see this, so here is the coming like a full thickness rectal prolapse as a in the form of circumferential induced susception. So that is one of the theories which is put forth by the Broden and Snellman. Then another theory which is postulated by Parks, that is stretching of the pudendal and perineal nerves during repeated straining at defecation. Then denervated external sphincter and puborectalis, and which is supported by the association between prolapse and incontinence. So most of the times this rectal prolapse is associated with incontinence, and this Parks theory. What happens in rectal prolapse? There is a straining, there is herniation of the rectum. So whenever there is a chronic constipation, then so there is a because of straining, there is herniation of the rectum through the muscular aperture of the pelvic floor. Then the mesorectum, there is lengthening of the mesorectum. Then there is stretching of the lateral and rectosigmoid attachments. Ultimately, it leads to the rectal prolapse, which is having contribution from this weakened pelvic floor muscles because of aging process or because of postmenopausal status. Then there can be sphincter defects like pudendal neuropathy, anorectal operations, or obstetric injuries because of repeated pregnancies, repeated deliveries. Then ultimately it will lead to patulous anus and the incontinence. And there is a chronic reflexive relaxation, appropriate leakage of the stool and mucus. So that's why the rectal prolapse and incontinence, they are contributory to each other. Now, what is the clinical presentation? How the patient will present? The complete prolapse, you can see, you can diagnose it easily. But for first degree and second degree, it is little difficult for us to make the diagnosis. So we should know what are the very symptomatology that may a patient can have, like sensation of the protrusion of the tissue through the anus, persistent hemorrhoids, mucoid or bloody discharge, constipation, straining, incontinence, incomplete evacuation, then history of perineal pressure and excoriation of the perianal skin. So this is how the rectal prolapse looks like. Now it is very, very important for us to differentiate between the rectal prolapse and a prolapsed hemorrhoids. Okay, so it may get confusing whether it is a rectal prolapse or whether it is a prolapsed hemorrhoid. So how to differentiate in between these two? So rectal prolapse is always circumferential while hemorrhoids are radial. Sulcus between the prolapse part and the rectum is circumferential, where there is no evidence of such sulcus in case of hemorrhoids. Abnormality on palpation, you will get a double rectal wall in rectal prolapse, while you will feel hemorrhoidal plexus in case of prolapsed hemorrhoids, and the resting and that is very, very important. And in hemorrhoids, it will be normal. Okay. Then what are the complications of the prolapse? So whenever it's a long-standing prolapse, or patient may come in emergency hours, maybe with a strangulation. There can be ulceration, there can be urinary and fecal incontinence, and there can be spontaneous rupture with evisceration. Now the very, very important how to diagnose it. If it's very evident, no problem. Okay, but the evaluation of patient is very lacerated, and that may require a surgical emergency. So we must rule out the incarceration. Now, when the patient comes to you, how to go ahead with it? So the history is important, like when does it occur, what are the associated symptomatology, then patient's general health and associated medical problems we must ask for, then whether there is any association with the psychiatric illness, then the complete physical examination is very, very important. Then the colonoscopy is very important investigation when we'll pose the, or when we will decide the management of the rectal prolapse. There is so much of list of investigations, but colonoscopy is important investigation, and to rule out the additional pathology such as neoplasm which may cause prolapse. So that's why endoscopic evaluation is must in case of prolapse. Now we will see one by one. The barium enema has its own role. Nowadays, because of colonoscopy, the barium enema has almost a vanishing investigation. But for a case of rectal prolapse, barium enema is very, very important investigation, because it is a better indicator for a redundancy of the colon, which may not be appreciable on colonoscopy. So that's why barium enema has its own place when the patient comes with a rectal prolapse. Then another investigation is anorectal manometry and the pudendal nerve terminal motor latency that should be considered in patients when there is associated fecal incontinence. Then colonic transit studies, then MR difficographies, endorectal ultrasounds, then cine difficographies. So there are so many investigations which are available. So depending associated symptomatology, along with the prolapse, we should go ahead with the proper investigation to prevent the further recurrence and to prevent the complications like impacted or severe constipation in a post-operative period. So that's why we will just see what are the various investigations that can be done. So one investigation is video difficography. in which the documentation of the internal prolapse or to distinguish the rectal prolapse from the mucosal prolapse if it is not clinically obvious. Then this video difficography is very, very useful. It is not to be done when there is a full thickness rectal prolapse. That is important to understand. Now there is a grading system on this difficography, and the grade 5 is considered as a complete prolapse, and depending upon the various things like non-relaxation of the puborectalis or mild intussusception. So depending upon that, there are various grades on difficography. The another very important investigation is the anorectal manometry. Whenever the patient has associated fecal incontinence, then anorectal manometry is very, very important investigation to be done. Okay, and most of the times the significance of these results may not be clear, so the surgeons may or may not do this manometry test. Then the another important study is SITS marker study to know the colonic transit time. Then the rigid proctosigmoidoscopy to assess the rectum for additional lesions, especially when the patient has rectal prolapse with the solitary rectal ulcer. So that is important investigation. And whenever you had some suspicious lesion or whenever there is a solitary rectal ulcer, you must take the biopsy from that solitary rectal ulcer to rule out the any associated neoplasm. That is important. And the colonoscopy has to be done in a case of rectal prolapse. The another investigation is endoanal ultrasonography for knowing the sphincter status. Okay. Because if there is associated sphincter problem, that can be tackled during the surgical management of the prolapse to prevent the further incontinence. Then MR difficography that clearly shows the pelvic visceral prolapse, and this MRI shows pelvic visceral prolapse and the pelvic floor configuration on straining, and the MR difficography that provides very useful information regarding the presence and degree of the anterior pelvic compartment descent that may need to be addressed if a good functional outcome is to be achieved. But the only problem with MR difficography is how expertise should be available for reporting of this MR difficography. Then only there is point in going ahead with this investigation. In selected cases, we may have to go ahead with the X-ray spine whenever we are suspecting some neurologic disease. Then the biopsy, as I have told you, whenever you are having some suspicious areas during endoscopic evaluation, you must go ahead with the biopsy. Now, a very, very important aspect of this rectal prolapse, after knowing what can be the associated other abnormalities along with the rectal prolapse, now how we should do the management, or how we should go ahead with the management or treatment of such patients. Now, the main aim of treatment of this rectal prolapse is to control the prolapse. Then the second important aim is to restore the continence. Then third important point is patient should not get constipated in a post-operative period and impaired evacuation. Okay, so we have to treat this constipation, or patient should not have constipation in a post-operative period, or impaired evacuation should not be there in a post-operative period. So our aim of treatment should be like this. And there are so many procedures which are described for this rectal prolapse. I will just give you in brief what are the various procedures. There are basically two modalities of management: non-operative and operative management. But non-operative has not much role in a case of rectal prolapse. But when surgical treatment is contraindicated, or if the patient refuses surgery, then we have to go ahead with the medical management, like adhesive strapping of the buttocks. It is not at all useful, but it is just the temporary measures. Then manual anal support during the defecation, correction of the severe constipation, then perineal strengthening exercises, injection of the sclerosing agents, infrared coagulation, the rubber-link ligation, so which are various therapies which have been described. Then high fiber diet, biofeedback, it may be helpful for the patients with internal intussusception and inappropriate pelvic floor contraction, but it doesn't play a significant role actually in the management of the this rectal prolapse. Now, when we think of a surgical management, then the goals of surgery are, whenever there is a redundant sigmoid colon, we have to resect or do the plication of that redundant colon. And the another important point is we have to fix the rectum to the sacrum. Okay, so these are the two important goals of surgery. And the two approaches for this surgery. We can go ahead with perineal approach. We can go ahead with the abdominal approach. Pros and cons of every approach are there. Okay. When we think of the abdominal approach, what are the steps, important steps? Though there are so many surgeries for abdominal approach or so many surgeries for perineal approach, but the principle of the management remains the same. So for the abdominal approach, first step is the mobilization of the rectum that involves the dissection between the mesorectum and the presacral fascia. As we have already seen in the surgical anatomy, we have to create a proper plane in between the mesorectum and the presacral fascia. Then mobilization is taken down to the level of levators. That is also very, very important. How much we should dissect. And the anterior mobilization should be taken to the level of vagina or seminal vesicles in female or male patients. Okay, so this is the principles of abdominal approach. Now, what you are supposed to do for incomplete rectal prolapse? If only one quadrant of the mucosa is involved, then simple excision is done, leaving the wound open to heal by granulation. And if the protruding area is circumferential, then excision with S-plasty may be considered. And the circular stapler is also being used recently for the management of this mucosal prolapse. And Delorme's procedure can be adopted. So whenever there is a this incomplete prolapse, we can do this excision and we can do this suturing. Okay, so the excessive prolapsed mucosa can be excised either by use of staplers, or nowadays so many advances are coming for these procedures. And for complete rectal prolapse, many techniques have been described. But what are the different techniques? They will differ in the extent of rectal mobilization, the methods used for the rectal fixation, and the inclusion or exclusion of the resection. So whether you are going to go ahead with the this resection of the colon or not. Now, for this complete rectal prolapse, the perineal approaches are either simple anal encirclement like Thier's procedure, which is most commonly done, especially in a pediatric age group or a old age group where patient is not fit for surgery. Then another is Delorme's procedure, and the third one is perineal proctosigmoidectomy, that is also known as Altermeier's procedure. Okay, and nowadays the upcoming procedure is STAR, that can be also done. And the abdominal approaches, which include suture rectopexy, prosthetic or mesh rectopexy, that is posterior mesh rectopexy, or anterior sling rectopexy, that is also known as Repstein's procedure. Then resection with or without rectopexy. Okay, so either you will just do the dissection all around the rectum, you do the rectal mobilization, and just do the this fixation of this rectum to the sacrum or the presacral area, and it may be associated with resection, which may not be associated with resection. Then it can be open surgery or it can be laparoscopic surgery. Okay, and the neuromodalities are like a STAR procedure. So all these are the various procedures which are available for this rectal prolapse. So we will just see in short what are these procedures. So about this anal encirclement, which the principle behind this anal encirclement is which stimulates the fibrosis around the anus to support the pelvic floor. Now, what are the various materials which are used? Like wires, fascias, tendons, then nylon thread. It can be mesh or it can be Teflon. Okay, and the this advantages of this, it may be performed under local anesthesia. Very short time is required and very little operative trauma is there. But there are so much significant disadvantages, that is, it doesn't address what is the underlying anatomic abnormality. Okay, we are just preventing what is the coming out. We are just trying to push it back. Okay, but the prolapse is going to remain there internally, and the failure rate is almost up to 80%. And the post-operative constipation and recurrent fecal impaction is very, very common after this anal encirclement. and the infection and erosion of the loop into the anal canal or through the perineal skin can occur. So this is the way everybody must have this seen how this here stitch is taken. So halfway circle we are taking out, then we are completing the circle and we are tying the knot in the this posterior aspect. Okay, so this is the way this tear stitch is taken, and temporarily we are trying to this rectal prolapse. Now another very important procedure, perineal procedure, is the mucosal sleeve resection. That is also known as Delorme's procedure. So what is done in this? There is a stripping of the mucosa and plicating the bare muscle to this collapse the wall like an accordion and the resuture the mucosa. Okay, by shortening the mucosal length and creating a fibrosis in the plicated rectal muscle, the rectal prolapse could be controlled. Okay, but it is having a very high recurrence rate. So these are the various steps how it is done. The patient is put in a jackknife position, eversion of the rectum, submucosal injection of the anesthetic drugs, circumferential incision of the mucosa. I will show you the intraoperative photographs. Then dissection of the mucosa from the muscle, plication of the rectal muscle, and the resection of the mucosa and anastomosis. Okay, so this is the Delorme's procedure. Eversion of the rectum, then this way you can do the plication and fixation of this after plication of the muscle, fixation of this mucosa to the muscle, and we are preventing this rectal prolapse or repositing back to the normal. So this is the Delorme's procedure, but this recurrence rate is very high in these cases. Okay, so the one of the series almost complication rate, it is almost 16%, and the recurrence rate almost it is what you can say 11 out of 14, almost we can get the 11 cases recurrence rate, means it is very high. Then another is Allet-Mears procedure, okay, or that is also known as perineal rectosigmoidectomy. In these cases, the eversion of the rectum is done, submucosal injection of the anesthetic, circumferential incision through the rectal wall, mobilization of the rectum and division of the mesentery, ligation of the hernial sac, and afterwards this levateroplasty and proximal transection of the rectum and the anastomosis. So that is done in the perineal rectosigmoidectomy. And the indications of this procedure, whenever there is profound comorbidity and when the abdominal procedure is contraindicated, and especially when the patients are elderly and high risk patients with incontinence, you should go ahead with this surgery. But the disadvantages, urgency for defecation, there can be soiling, and again there can be high recurrence rate. So when we are considering this perineal surgeries, so the recurrence rate is comparatively very, very high. But that's why very high risk patient, and to give a little better quality of life, we are trying all these perineal procedures. So these are the various steps that I have already told you for this Allet-Mears procedure. Okay, so the rectum is everted, anesthetic is injected submucosally, deepened through the rectal tube until perirectal fat is encountered, then division of the mesentery, and after that this levateroplasty is done, and this anastomosis is done, end-to-end anastomosis. Okay, again there are significant complication rate and the significant recurrence rate are there. Then the another procedure, that is Gant procedure. So there are so many perineal procedures which are being described, but again there are complications with these procedures like anastomotic leak, then pelvic sepsis, early bleeding, late bleeding, then anastomotic strictures. All these are the known complications of this perineal procedure. The advantages of this procedure, that as we are not entering the peritoneal cavity, so avoidance of the peritoneal adhesions, short hospital stay, low risk of injury to the pelvic nerves, options of spinal anesthesia, reduced pain, and concomitant repair of sphincter defects, hemorrhoids, rectocele, or vaginal prolapse. So when we are dealing with the perineal approach, these are the advantages, but the disadvantages, very, very high recurrence rate and reduced improvement of any fecal incontinence. So patient may have a fecal soiling in a post-operative period also. Okay, so it is a choice of procedure only in elderly patient or with multiple comorbid condition and very, very high risk patients where abdominal surgeries may not be possible. Then what are the various abdominal procedure, which is the most commonly preferred option? So there is a rectopexy or the resection with rectopexy. Okay, rectopexy means we are just doing the mobilization of the rectum and fixing of that rectum either with the suture or with the some mesh or with some evalon sponge. Okay, so the suture, then next is Repstein's procedure and the use of evalon sponge for this achieving the this what you can say anchoring of the rectum to the sacrum. And the second one is resection along with suture rectopexy. Okay, that is known as Friedman-Goldberg procedure. So that we will see what are the various procedure. Now indications whenever there is full thickness rectal prolapse, especially in a young or middle-aged, we should go ahead with this abdominal procedures, and especially not by open approach but by laparoscopic approach. There is a significant circumferential rectal intussusception which is causing obstructed defecation. So the STAR procedure is very, very helpful whenever there is obstructed defecation syndrome. And the MR difficography is a very, very important investigation to diagnose this rectal intussusception with obstructed defecation syndrome, because these cases are very difficult to diagnose and patient may remain undiagnosed and he may suffer lifelong unless and until you diagnose these conditions. Then there can be associated solitary rectal ulcer. Then in such cases, you should go ahead with the abdominal approach. It should be performed in a younger, healthier patients whose life expectancy is longer. And the choice of abdominal procedure is dictated by the extent of associated constipation and by surgeon's preference and expertise available. That is also very, very important to understand. The contraindications is whenever there is a previous abdominal rectopexy, especially with the large bowel resection or pelvic mesh, there are extensive adhesions which are expected. Then the sexually active male patients and morbid obesity. In such cases, you should go ahead with the perineal procedures. Now the suture rectopexy, what is done? The mobilization and the subsequent healing by the fibrosis tends to keep the rectum fixed in an elevated position as adhesions form attaching the rectum to the presacral fascia. That is the principle behind this thorough mobilization and upward fixation of the rectum. So how it is achieved? It is achieved by this way. Okay, so that is the suture rectopexy, and that is the very, very important surgery that everybody must know for this rectal prolapse. So it is the mobilization of the rectum and fixation of the rectum to the presacral area. Okay, then what is this Repstein procedure? Entire rectum is mobilized down to the coccyx posteriorly and the lateral ligaments laterally and the anterior cul-de-sac anteriorly, and the non-absorbable material such as non-absorbable mesh is fixed to the presacral fascia. Okay, and the rectum is then placed on the tension and the material is partially wrapped around the rectum to keep it in a position. So this is the Barlett's rectopexy. So presacral area, we are mobilizing the rectum. We are mobilizing the rectum anteriorly also. So anterior, posterior and lateral mobilization, and we are using this Marlett's mesh which keeps this rectum in a position. Okay, so this is the Marlett's rectopexy. So it causes inflammatory reaction that scars and fixes the rectum into place. Okay, but very, very important to understand that it should not be performed in patients having large component of the constipation or whenever there is redundant sigmoid colon, because post-operative period must this will be much more worse than before surgery. Okay, so that's why proper evaluation of the patient is very, very important, and the type of operation that you are selecting for that particular patient is very, very important, and the complications that can occur as pelvic abscess or extrusion of the mesh or sponge. Okay, so these are the various complications, but it is having a very low recurrence rate and the complication rate is also less. The only if there is no proper what you can say selection of a patient, there can be this so much of a fecal impaction. Okay, so that is important to understand. Then the another is eval sponge repair. It is almost the same. The only thing here, only 2/3 circumference is covered. Okay, rest of the steps are the same. Then the resection rectospexy, it is again the same. The only thing, colon is anastomosed to the top of the rectum. Okay, and the rest of the procedure again remains the same. That is the resection rectopexy. Now the advantages of this resection rectopexy, that the resection of the abundant rectosigmoid which avoids torsion or volvulus, achieving a straighter course of the left colon and the little mobility from the phrenocholic ligament downward, which acts again as another fixative device, and the relief of the constipation in a selected group of patients. Okay, so this selection is very important type of surgery that you are going to do. Okay, so this is the redundant sigmoid that we are going to exercise in this procedure, and this anastomosis of this resected part to the top of the rectum. Okay, and after that sacral fixation. Okay, so that is the Frickman-Goldberg procedure, that is resection rectopexy. Okay, so these are again the steps to show the same steps. Now the important is in this era of laparoscopy, mostly the laparoscopic procedures are preferred. Not only just for suture rectopexy, but for resection rectopexy also. Okay, so the laparoscopic procedures are preferred. This is the layout of the operation theater. I am having video, but because of lack of time, it will be difficult for me to show the videos. If you permit, I can share these videos with you. So with all these procedures, the videos are available, but these are lengthy videos, so it is not possible for me to cover in this slot. Okay, so in these cases, laparoscopically, the after mobilization, this mesh is inserted into the abdomen through the port and then stapled to the rectum, and the lateral edges of the mesh are wrapped around the 3/4 of the rectal circumference and sutured to the rectal wall. Okay, so in this way, this suture rectopexy is done laparoscopically. Okay, so this is the way it is done. Now, what are the advantages of laparoscopic rectopexy? So, as advantages of other places of laparoscopy, same like reduced pain, shorter hospital stay, early recovery, and early return to the work. Then the procedure involves, as I have told you, either it can be just suture or posterior mesh rectopexy with or without resection. Okay, it has gained the popularity as it is relatively simple and easily accomplished, and the resection with the anastomosis is avoided. Okay, but the only thing, you should have expertise available. Okay, and the studies have demonstrated that the approach is as effective as the open method in the treatment of rectal prolapse, and the effect on the continence and constipation depends upon the type of rectopexy performed. Okay. Now the few special considerations, just last 5 minutes. In pediatric age group, unlike adults, they may respond to the treatment underlying the medical condition. So mostly in a pediatric age group, we may not have to go ahead with any operative intervention. They will very well respond to your conservative line of management. But and 90% of the prolapse we get in a less than 3-year-old age group, and mostly they are associated with either very too much of severe constipation or post diarrhea. Okay, so that pediatric population, they should not have straining at stools, and they should have a proper toilet seats. So that is very, very important. And the diet that we are giving to the patients is important. Many times milk may cause severe constipation, so that advice we should give, which type of milk should be given, whether that child's body is this getting milk digestion properly, or whether that only causes the severe constipation, that should be taken care of. Then the sclerosant therapy is also helpful in a pediatric age group. Now the special situations, like whenever there is incarceration, strangulation or gangrene, when the patient comes with such a situation in emergency, so what to do in such cases? If the bowel is viable, then sedation and gentle manual reduction in an emergency. Okay. For incarceration, for this gangrene, we may have to go ahead with the emergency perineal rectosigmoidectomy. Okay. So depending upon what type of situation, we will have to deal in an emergency operation theaters. Then when there is a ruptured prolapse that involves the opening of the hernial sac and exposure of the small bowel also to the perineum, then in such cases, emergency transabdominal repair is always advisable and not perineal procedures. We have to close the peritoneal hernial sac and suture the rectopexy, constituting the safest and most efficient repair. So that's why we should understand what is the basic theories behind this prolapse. Okay, so it's nothing but it's a type of intussusception. Okay, so or it's a type of sliding hernia. So when you will deal with such cases, you know how to repair these, how to go ahead with the definitive operative management in such cases. Then prolapse in male patients, again we have to be very careful, because this lateral pararectal tissues carry the parasympathetic fibers, and they are very important in a normal ejaculatory function. So when we will deal with the young males, we should be very careful when we will deal with this rectal prolapse. Then whenever there is a recurrent prolapse, the surgical intervention corrects the anatomic abnormalities present, and the functional disorder often persists, resulting in a tendency for the prolapse to recur. Okay, and these recurrence rates are generally higher with the perineal operations than with the abdominal operations. So when we will decide which type of surgery that you want to this giving choice to the patient, so you should be very careful. And the early recurrences, those occurring less than 2 years after operation, these are thought to be related to the technical factors which are associated with the original procedure. So we should not repeat those mistakes again when we will deal with the recurrent prolapse. Okay. Then the solitary rectal ulcer syndrome, again we should not neglect this. It is, and many times it is associated with rectal prolapse. So we have to treat the prolapse, automatically that ulcer gets healed. The only thing we have to rule out the neoplasia. So to conclude, rectal prolapse, it is a complicated disease process due to combination of the factors that we have already seen. So the thorough preoperative workup is very important to determine which procedure you are going to opt for. Then the choice of operation is based primarily on the procedure chosen for the initial management. So for the abdominal procedure, for the second operation, regardless of what the initial operation was done, because of the superior rates of success with such procedures, then the risk of bowel ischemia between the two anastomos is more when you are doing a repeat resection procedures. Then perineal rectosigmoidectomy can be safely repeated because the recurrent prolapse contains the previous anastomosis. This thing we should understand. Okay, so we can go ahead again with the resection rectopexy, and the recurrent rates and the morbidity after operative treatment of recurrent rectal prolapse are essentially the same as those after operative treatment of the primary rectal prolapse. So that you should tell to the patient beforehand. So how you will choose? If the patient is fit, young male, you should always go ahead with the laparoscopic suture rectopexy or the resection rectopexy, depending upon whether there is a redundant sigmoid or not. Okay, and the lateral dissection, you should be very careful to prevent the injury to the parasympathetic nerves. And the unfit patient or patients with incarcerated, strangulated, and gangrenous rectal prolapse or elderly with comorbid condition, we should go ahead with the perineal rectosigmoidectomy with levateroplasty, that is Delorme's procedure. Okay, so this is just the flow chart how you will select the procedure. Okay, and a few words about the STAR, that is stapled transanal resection of the rectum. Nowadays, it is very commonly done procedure through the anal canal to remove the loose floppy rectal wall using a special stapling device. So this operation is performed especially for the patients with the obstructed defecation syndrome. Okay, so for this partial prolapse, or the grade 1 and grade 2 prolapse, star procedure is very, very effective for this mucosal prolapse. So this is the way this is done. Okay. And once again, I am very, very thankful for the organizing committee for giving me the this opportunity, and nice to see you all again on this virtual platform. Thank you very much.
Thank you so much, ma'am. I cannot explain how delighted I was to be listening again to you, ma'am. It was a very nice talk, ma'am. So everything from anatomy, which we are always very weak at as surgeons, because that is a very basic thing which we actually do not look up to. But ma'am, thank you so much for conveying it so in such easy words, as well as everything, ma'am, from basic medical management to the surgical management and the newer technology like STAR. Ma'am, we shall surely remember it that way. Thank you so much, ma'am. We really miss you back here at Savangi, ma'am.
Thank you very much.
Good afternoon, madam. Dr. Gattani here. Thank you,
Hello, sir.
madam.
Hello.
Thank you, madam, for enlightening us in detail on this topic. Thank you very much.
If you want to add something, sir, you are most welcome. You can add to it if there is
thank you,
something
madam.
that I have missed.
Yeah, nice talking to you, madam. Nice listening to you. Thank you.
Thank you very much.
Ma'am, if you could please hand over the
Yes.
yes, right, yes.
Where to click? Just wait. I will call someone. Just wait.
Yes, ma'am. Participant.
That host, no, that I have to. It's not coming. And
Department of Surgery.
no.
It just go to the participant and kindly transfer the host rights to Department of Surgery.
Yes, we are doing, please. Department
Yes,
of Surgery, we are fine. Department.
It's not seeing.
Yeah.
No.
Make
host, yes. Change the host, yes.
You are.
Ma'am, it's done, ma'am.
Okay. Thank you very much, Shruti. Yeah, we will have to stop share.
Thank you, ma'am. Now I would like to invite Dr. Sanjeev Gyanchandani, sir. Topic for his discussion is rectal incontinence. Sir, I'm starting.
Good afternoon, everyone. I am Dr. Sanjeev Gyanchandani, Assistant Professor from Department of Surgery, Jawaharlal Nehru Medical College. And I'm thankful for the organizing committee to give me an opportunity to participate in this conference. And I also welcome.
Sir, just one thing, sir. Sir, if you could please start the slideshow, sir.
Yeah, I've started already.
So just you'll have to change the mode, sir.
Something has to be changed.
So 1 second, sir. Yes, sir.
Can
It's
you see the
visible now,
screen
sir. Yes, sir. Yes, sir.
Okay.
Thank you, sir.
Yeah, everything is good now.
Yes, sir. Yes, sir.
We can see your presentation, sir. Please start. Sir.
Yep. Thank you very much. So today's topic of discussion is fecal incontinence. I am Dr. Sanjeev Gyanchandani from Department of Surgery, Jawaharlal Nehru Medical College, and I'm thankful to the organizing committee to give me an opportunity to participate in today's presentation. And we also welcome Meenakshi Evla ma'am, and we are happy to have you, ma'am. I have no disclosures to make, and neither I have any conflict of interest with today's presentation. Fecal incontinence is involuntary loss of rectal contents, feces or gas through anal canal. In addition to this, it is also the inability to postpone an evacuation until it is socially convenient. There are two more criteria in it, which is the duration. It should be more than 1 month, and the age of the individual should be above 4 years with previously achieved control. Coming to the classification of fecal incontinence, it is passive incontinence, which is involuntary discharge without awareness. So the patient does not have the urge to defecation, and it leads to an involuntary continuous discharge. Furthermore, it is urge incontinence in which the patient has awareness and has an urge for defecation. However, his inability to hold it for a substantial amount of time, so it is socially convenient for him to pass motion, and that is also included in incontinence. Further is a minor form of incontinence, which is seepage, and it is leakage of stool with almost normal continence and evacuation. However, there is fecal seepage intermittently in between. Now, before going further, we need to understand the components of continence, which includes anatomical consideration like anal sphincter complex, the consistency of stool. Further, it is rectal reservoir function and elasticity, and neurological functions. All these 4 components are important for maintaining continence. Peculiar to the surgeon, it is the anatomical consideration, the anal sphincter complex, which is important. So, in the anal sphincter complex, the internal anal sphincter, the external anal sphincter, and puborectalis are important. This topic has been already covered, so I'll just move forward looking at the constraints of time. So, surgically, as I said, the muscular complex like puborectalis sling, external anal sphincter, internal sphincter are important. In addition to this, hemorrhoidal cushion is also important. And the configuration and angulation canal is important in maintaining the continence. So the puborectalis sling and external anal sphincter are striated muscles with slow twitch, and they are fatigue resistant muscle fibers.
Hello.
Usually,
Hello.
yeah.
Hello.
Yes. Yes, Dr. Vilas, I can hear you.
Yes, sir.
Sorry. So these muscles are usually contracted, and defecation is caused by relaxation of the muscles. External anal sphincter leads to resting anal pressure, and voluntary squeeze pressure is also there. So when there is a voluntary squeeze, which we do on per rectal examination, is usually because of the external anal sphincter. This is the diagrammatic representation of the puborectalis muscle with the anal sphincter and the angulation of the anorectal region. Coming to the internal sphincter, it is, I'm going superficially over the anatomy as it has already been covered. So these are smooth muscles and it has an autonomic innervation. Now coming to the humeroidal cushion, which also leads to 10 to 15% of continence and which seals the anal canal. So if there are problems in this humeroidal cushion, which leads to hemorrhoids and it protrudes downwards, and if it passes through the anal canal, it can also lead to soiling and incontinence. And furthermore, it gives away the sealing effect which it has for continence. Now this topic is very important, the configuration of anal canal. Important components to it. One is the radial musculature, the internal sphincter as well as the external sphincter, which causes a radial force on the anal canal. If there is a distortion, deformity, or altered texture of this musculature, it will lead to incontinence. Furthermore, there is angulation between the rectum and the anal canal, which has already been described, and which is created by the puborectalis sling. And this part is important. And we need to understand that the rectum is a reservoir of the fecal matter. And by the angulation, the fecal matter is kept in the rectum. And then once the puborectalis relaxes, it passes through the anal canal. And if this component is lost and there is damage to puborectalis muscle, there'll be a straight passage from the sigmoid to the rectum and then to the anal canal, which will lead to severe incontinence. Coming further downwards, there are internal and external sphincter, which are also important in maintaining the continence. Once we have understood this, we can understand that it is, if there is dysfunction of the puborectalis, as I've already mentioned, it will lead to a complete incontinence. The patient will not be able to hold the fecal matter in the rectum. Then if there's only injury to the external anal sphincter and not to the puborectalis muscle, which are almost attached to each other, and if there's only isolated external anal sphincter dysfunction, it will lead to an urge incontinence, where the patient will have the feeling for defecation. However, a voluntary control for the patient would be difficult. Internal anal sphincter dysfunction usually does not lead to incontinence, as we do lateral sphincterotomy surgeries, and we have seen that they don't lead to incontinence. However, it can lead to minor incontinence in terms of seepage of stool or gases. So, mostly as per from the surgical perspective, we will get patients which have structural abnormalities, and the patients would have injuries to the anal sphincter complex. It could be obstetric injury, it could be an anorectal surgery like hemorrhoidal surgeries, fistulas in ano, fissure in ano. Rectal interception or prolapse can also lead to injury to the sphincter. Furthermore, abdominoperineal resection or sphincter preserving APR surgeries can also damage the sphincters. And definitely APR, we remove the muscular component. Then is trauma to the pelvis, perineal region, and anal region, which would be peculiar to a surgeon. So the surgeries for fecal incontinence would first be the repair of the anal muscle injuries, and most commonly would be the external anal sphincter. Furthermore is muscle transposition, where gracilis flap is used to transposition it across the anal canal to maintain continence. There are few more options like artificial sphincters. However, they are not well accepted and the results are not that great. Then the final solution to it would be making a stoma. If nothing is working for the patient. The first surgery would be anal sphincteroplasty. So we put the patient in lithotomy position and a circular incision is taken over the defect. You can identify the defect like this, which is a keyhole defect, where you can see the upper end and the lower end of the defect, and that is where the external anal sphincter lies. So you take a circular incision there and you inject local adrenaline, which is preferred, and that will lead to less blood in the field of operation, and that would be better to identify the muscles. Following the circular incision, you just podally dissect gently, and you have to be careful that you do not damage the anal canal. Then you move your dissection circumferentially and you identify the muscles. At least 1 to 2 centimeters of external sphincter has to be dissected. And you can see the external sphincter very well, and you can see the fibers arising from the skin. And over the skin also there are some muscular fibers. So when you do the closure, you should remember that skin you have to close very well. So after dissecting 1 to 2 centimeters of sphincters, it is advisable not to dissect more, because the more you dissect, there are likely chances of damaging the nerves. Then you do an overlapping sphincteroplasty, where you keep one part of the muscle over the other, and you do U-shaped sutures to fix it. It has to be remembered that the sutures has to be just tight enough to approximate it. If you make it too tight, it can lead to compromise of the vascularity. This is a case that I had operated around 2.5 years back, which had a complete perineal tear. And as per the history of the patient, it was after a attack by the bull. We had suspicion of other causes of such traumatic injury. However, there was consistent history by the patient and the family members that this trauma has occurred after a bull's attack. So if you can see this patient, you can see the vaginal mucosa very clearly and external anal sphincter very clearly. And medial to the external anal sphincter is the internal sphincter. Here you can see the complete dehiscence of the perineum. Once this patient was referred to us by the gynecology department, it was quite infected, and we gave a thorough lavage initially, and then the next day we kept it for surgery. Yeah, that's the perineal body you can see, which lies between the rectum and vagina, and it is the condensation of all the muscles of perineum. It is approximately 2 centimeters in diameter, and it is a firm muscular component which is important for the pelvis, and the repair of this structure is very important for future of the patient, as the patient will have pelvic floor dysfunction, which can lead to fecal incontinence, urinary incontinence, prolapse, and multiple other things. You can see the two cut ends of the rectum very well, and from this closure, or even if it is a complete perineal tear or just the sphincter injury, you have to start repairing it from down above. So you start repairing the rectum first, and you start from the most distant end and come towards the anal canal. Once you have approximated the rectum and anal canal, you can follow further down to identify the internal sphincter. Internal sphincter are pale as comparison to external sphincter and continuum to rectum, and which can be identified easily. These are the two ends of the internal sphincter after the closure of the rectum and anal canal. Now, the approximation of internal sphincter are controversial. There are schools of thoughts that if you do overlapping sphincteroplasty of internal sphincter, it can lead to painful defecation and fissure. However, in my experience, whatever repairs of internal sphincter I've done, none of the patients had some complaints. Following this dissection of the internal sphincter, there's a groove between the internal sphincter and the external sphincter, and which can be clearly dissected off, and then you can have a good chunk of external sphincter. And external sphincter is just below the perineal body and transverse perineal muscle. And you can see it arising from the skin, the subcutaneous part of the skin. For this also, you have to do overlapping sphincteroplasty with a two U sutures you have to take. And then it gives very good results if it has been done meticulously. Furthermore, that's the perineal body in which you have to approximate the external sphincter, the transverse perineal muscle, and the perineal body all together. And then it will have a good perineal repair to avoid further complications of pelvic floor. This is the closure of the patient we have done. And furthermore, when you go, if there's a complete perineal tear and not just external sphincter injury, you have to also approximate the bulbous spongiosis properly so that it leads to a good closure. And this is the final picture of the patient with no. And in the later follow-up, patient did not have any pain while defecation, and neither she had any pain while sexual intercourse. There's one further surgery which can be done for fecal incontinence, which is important for surgeon, is gracilis interposition. Gracilis is a superficial muscle on the medial aspect of thigh. It arises from pubic symphysis and also from the inferior ramus of the pubic bone. And it is inserted on the medial surface of the body of tibia. During the surgery, the anatomical location of the neurovascular pedicle is very important, which is 4 centimeters below the lateral edge of the pubic ramus, which has to be preserved. There are few perforating vessels which enter the lateral aspect of gracilis, which can be safely ligated and does not lead to any vascular compromise of the muscle. So the patient is positioned in lithotomy position, and the incision is made on the medial aspect of thigh behind the long sphenosphere. The perforating vessels are ligated, the neuromuscular bundle is identified and spared, and then a tunnel is made from the medial aspect of gracilis towards the anal canal, and then the anal canal is circumferentially dissected above. It should be at least 2 centimeters above the defect, or it should be the entire length of the anal canal. Now, once you have dissected, you position the muscle circumferentially around the anal canal, and then the distal end is fixed to the ischial ramus. The transposition muscle is also fixed around the anal canal with multiple sutures. Now, this leads to a squeeze mechanism and improves incontinence. However, there are few complications like infection, bleeding. There could be necrosis of the muscle fiber, and it could lead to a revision surgery. There are 2 components of gracilis interposition surgery. One is aerodynamic, where you do not use neurotransmitter to contract the muscle. And the next is dynamic, which is more preferred these days, where you put a neurotransmitter above the pubic bone, and which leads to continuous stimulation of the muscle, leading to contraction. And there's a magnet kept with the patient, And when he has the urge to defecate, he brings it towards the neurotransmitter plate. And once the magnet comes in contact with the neurotransmitter plate, it stops, which leads to relaxation of the sphincter and a easy defecation. This has been successfully performed at multiple institutes and claims to have substantial results. So coming to the conclusion, fecal incontinence is a major morbidity and leads to poor quality of life, has poor socioeconomic impact and poor socioeconomic life. Substantial cost is added by use of diapers, continuous treatment, surgeries. And anatomical disruption is a common etiology and is surgically correctable, which is important for surgeons. And a meticulous anal sphincteroplasty has good results. Furthermore, if after meticulous sphincteroplasty or after some surgeries where the sphincters have been removed, a gracilis interposition with dynamic pacing is also a good alternative option. In patients, complete damage to the anal sphincter or patients with abdominoperineal resection, bilateral gracilis can be used to create the neo sphincter, which also gives substantial continence, and patient can have a better quality of life. These are the references, and all the words of wisdom are from them. Thank you very much. I'm really thankful for the organizing committee to give me an opportunity to present this. And thank you to all the participants for patient listening. Thank you very much.
Thank you so much, sir. It was indeed a very good presentation, sir, because we see so many patients of incontinence who come under real distress. So it would be very helpful for us on a daily OPD basis for actually helping these patients getting relieved of their stress. For the next participant, I would
Sanjeev,
like,
Sanjeev, thank you so much for such a sweet and apt presentation.
Thank you, sir.
Thank you so much.
Thank you, sir.
Our next presenter is Dr. Kiran Khedkar, sir, a personal favorite among us residents, pediatric surgeon. His topic for today's discussion would be anorectal malformations. These are the patients we see the most in our pediatric surgery posting, and it is always a beauty of how sir operates them, and the results that we see and the happiness the patients have post the surgical process that they undergo. I would hand over the rights to Kiran, sir.
Yeah. Hello, good afternoon. Thank you, Kshiti. Myself, Dr. Kiran Khedkar. I am pediatric surgeon and working as assistant professor here in Department of Surgery at Jawaharlal Nehru Medical College, Savangi Mege. So today I am presenting anorectal malformations. It's a very common condition or anomaly which is seen in childhood. So what is it? It's not a single anomaly, but it is a spectrum of diseases which affects boys and girls. It involves malformations of distal anus, rectum, as well as urinary and genital tracts. It may range from minor, easily treated defects that have an excellent functional prognosis to a complex defects that are difficult to manage. There are various classifications which have been given from 1934 to last at 2005. So Krickenbeck classification, which was given in 2005, which includes major clinical groups and rare or regional variants. So major clinical group include perineal fistula, rectourethral fistula, which may be at bulbar or prostatic urethra, rectovesical fistula, vestibular fistula, which is seen in females, then cloaca, and anomaly without any fistula, and anal stenosis. Then the rare variants include pouch colon, which is exclusively seen in India. Then, rectal atresia or stenosis, which is also a very rare anomaly, and rectovaginal fistula and H-type fistula, where anus and vagina both are patent and normally formed, but there is a tract communicating both of them, and others which are very rare anomalies. Now, embryology. So multiple theories have been put forwarded, but recently it is said that it is due to defect in the dorsal part of cloacal membranes. So as we all know, embryology, anorectum as well as genital system and urinary system, which is formed from cloaca. So any defect in the cloaca will lead to these anomalies. Whereas defect is smaller, it will lead to distal anomalies. And when the defect in the cloaca is larger, it is associated with the major defect, which may be with the urogenital fistula or other major malformations. Now, epidemiology. So, incidence is 1 in 4,000 to 5,000 births. It is isolated anomaly in 36% of the patients. However, associated anomalies are seen in 63.6% of patients. Urogenital anomalies are commonly associated anomalies, which are seen in 20 to 54% of these patients. Incidence of fistula is 72% in boys and 90% in girls. In India, pouch colon is a type which is exclusively seen, especially in the North India, but it is seen everywhere in India. Now, associated syndromes. There are many syndromes which are associated, which include Down syndrome, Cat-Eye syndrome, Towne-Brock syndrome, FG syndrome, Pallister-Hall syndrome, Vactal association, which is commonly seen, then Serenomelia, caudal regression syndrome, and Currarino syndrome. Now, associated anomalies. So, in 50 to 60% of the babies, this condition is associated with other system anomalies. So, genitourinary anomaly is most common, and vesico-uretral reflux is the most common associated anomaly. Others are rectovesical fistula and cloaca. Then cardiac anomalies are seen in 10 to 15% of these patients. And others are sacrospinal anomalies, spinal cord anomalies, chromosomal anomalies, gastrointestinal anomalies, and associated syndromes. So while examining these babies, we have to rule out all these anomalies. Now, clinical features. So in males and females, clinical features are quite different, and their anatomy is also different. So in males, on perineal inspection, we can look for the presence or absence of anus and its position. The size of anal dimple, fistula if present or absent, and if present, then where is the exact position. Then anal membrane or meconium bulging in perineum, midline raphe and scrotum for fistula's opening. Then urethral meatus assessment, because many patients, they have associated hypospadias. Then bucket handle deformity, which can be managed in neonatal period, and meconiuria, which suggests very high anomaly or very big fistula between rectum and urinary system. Now, midline groove, when it is flat, midline groove means gluteal cleft, basically. If it is flat or rocker bottom perineum is there, it indicates poorly developed muscles, which is associated with poor muscle function. And this is typically seen in high anomalies. Then clinical appearance in female. So variations are many in female clinical appearance. Female malformation, 95% are low variety. Single opening if present in the perineum, that is common cloaca, means urethra, vagina, and rectum all are opening in single opening. So that is common cloaca, rare condition, very difficult to manage. Then when there are two orifices in the vulva and no anal orifice, so it could be because of rectovaginal fistula or covered anus, or anorectal agenesis, means there is normal vagina and urethra, but there is no opening for the anus. So when there are three orifices in vulva or perineum, okay, if the all three openings are at normal site, means urethra, vagina, and anus, all three openings are the normal site. This is seen in these conditions, which are called as perineal groove. That is, there is a strip communicating between anus and vagina. So we don't need to do anything, or we can resect that strip and everything will be all right. then there will be perineal canal. So perineal canal, urethra, vagina, and anus is at the normal position, but there is communicating tract between patent anus and vagina or anterior foreshoot. Then rectal atresia. In rectal atresia, there will be a normal external anal opening, but rectum will be atretic. So patient will not pass meconium. Then when the third opening is in the perineum, that means when it is there is absence of anus normally from vagina and urethra, and third opening is somewhere between anus and vagina. So these are the conditions which are anterior perineal anus, where anus is of normal caliber, but it is anteriorly positioned, and anocutaneous fistula. So there will be fistula in the perineum. Then when the third opening is at the vestibule, means this is called as vestibule, and if third opening is the vestibule, then it could be vulvar anus or anovulvar fistula or anovestibular fistula or rectovestibular fistula. But though the names are different, nowadays all these things are called as perineal fistula or vestibular fistula, and because the management is same. Then clinical examination of cloaca. The presence of single perineal orifice in a patient is clinical evidence of persistent cloaca. So cloaca is normal thing in embryo till some time, and it is normally seen in few birds also. But persistence of cloaca is something abnormal for humans. So patient with these anomalies also have small genitalia. Examination of the abdomen may reveal an abdominal mass that likely represent distended vagina, that is hydrocolpus. As urine may drain into vagina and it may cause distension of vagina, so this patient will have hydrocolpus which can be palpated in per abdominal examination. So this is pouch colon. So this is first reported by Trussler in 1954, but this condition is more common in North India. And this is a very high type of anomaly. As you can see, this is X-ray of neonate where the single gas shadow is covering more than half of the abdomen. This is typical. This is very much diagnostic of this condition. So these are the types of pouch colon. So type 1, here the whole of the colon and rectum is converted into pouch. This pouch is having very big fistula with the urinary bladder, and ileum is directly opening into this pouch. So during surgery, we have to remove this pouch, divide this fistula, remove this pouch, and get this ileum as a anal opening. So the continence will be poor in this patient. Now this is type 2, where some part of the cecum is there. Sometimes they may have 2 appendix, and rest of the colon and rectum is converted into pouch. So they may have better prognosis because of patent IC valve. Now this is third part. Sorry, type 3 pouch colon, where considerable length of the colon is present, and rest of the colon and rectum is converted into pouch. They have better prognosis, and this is type 4, where the most of the length of colon is there, which is normal, and only terminal part of the colon and rectum is converted into pouch. So in all these cases, they have big fistula with either urinary system or genital system. Okay, this is this thing diagram of female patient, and it is opening into vestibule. So management. So this is a management in newborn female with anorectal malformation. Okay. So the first thing, anorectal malformation is not a very fire brigade emergency. You don't have to rush to patient to OT immediately after birth. There is always time to examine and investigate patient. So rule out serious potentially lethal associated defect. Look for sacrum, then esophagus, because many patients they have esophageal atresia. Then look for kidney, do abdominal ultrasonography, do spinal ultrasonography to rule out spinal defects. And you can do cardiac echo to rule out cardiac defects, because these are all defects which are very commonly seen in clinical practice. Now on perineal inspection, if there is single orifice, so that means the patient is having cloaca, do urological evaluation, rule out hydrocolpos, and do colostomy. If hydrocolpos is present, we need to drain that hydrocolpos immediately. Otherwise, that will lead to obstructive uropathy. Because this distended vagina compresses on the ureters, both the ureters, which may lead to obstruction. Then if there is perineal fistula, you can do anoplasty. Then if there is vestibular fistula, so depending on the condition, you can do colostomy or primary repair. This primary repair can be done in neonatal period as well as in later date. There is no emergency. You can keep patient on rectal washes for few months, and we can do surgery at 2 or 3 months. So usually at our center, we do surgeries at 2 months, primary repair. So there is no added risk which is there in the neonatal period, as well as there is no colostomy required. If there is no anal opening and no fistula is visible, then the management is as same as male patient. We wait for 24 hours, do a cross-table lateral X-ray. If the anomaly is high, we do colostomy. If the anomaly is low or intermediate, we can do primary repair as well as we can do colostomy and do definitive repair at later date. So in newborn male, we can wait for 20 to 24 hours. Evaluate patient for spine, sacrum, kidney, ultrasonography, spinal ultrasonography, urinalysis, cardiac echo, and rule out esophageal atresia. Then re-evaluation, that means many times if there is small perineal fistula, we can see stool in the perineum. In that case, we can go ahead for the primary surgery. And if no meconium is seen even after 24 hours, we do cross-table lateral X-ray. If clinically or means after 24 hours, we can see perineal fistula, anoplasty is preferred. Then if on cross-table X-ray, if there is a high anomaly, we go for colostomy. If there is low anomaly, we can go ahead for the primary repair if patient is stable enough. And if it is intermediate anomaly, theoretically we can go for the primary repair in neonatal period. But at our center, we do colostomy and do definitive repair after 2 months. Well, these are the investigations which are done during neonatal period. These are invertogram, which is theoretically there, but now it is obsolete and nobody does it. Then sacral ratio, which can be seen on AP and lateral X-ray. Then this prone cross-table X-ray, which is very important investigation. Then transperineal USG, we can do transperineal USG, but practically not very useful investigation. Then USG spine and USG abdomen we do in all patients to rule out spinal anomalies and to look for any anomaly in the abdomen. Then after newborn period is over, means once we stabilize the patient, do stoma and all, then before definitive repair, we can do MRI to look for anatomy. Not very commonly done. It is done only in special circumstances where the presentation is atypical. Then pressure augmented distal colostogram. This is done in all patients who have done colostomy in neonatal period. Then micturating cystourethrogram. Whenever the patient is having hydroureteronephrosis on ultrasonography, we do micturating cystourethrogram. To rule out vesico-ureteral reflux, as I said earlier, vesico-ureteral reflux is very common anomaly which is seen associated with the anorectal malformation. So this is sacral ratio. We can see this is on the AP X-ray. This is iliac crest, and this is the lower part of this is lower part of SI joint. Okay. So basically, this is upper part of SI joint, and this is lower part of SI joint, and this is this thing, lower part of the coccyx. Okay. So in this figure, we can see so upper part of SI joint, lower part of SI joint, and coccyx. So these are the points AB and BC. So this this BC divided by AB means the length of the sacrum, basically divided by the distance between SI joint, upper and lower SI joint, is what we get a sacral ratio. So normal ratio is 0.74 on AP and 0.77 in lateral. If this ratio is less than 0.5, then there are significantly decreased chance of normal function or normal continence. So many patients with high anomaly, they have sacral agenesis, and you will get a lesser sacral ratio, and they are having poor continence. Then this is cross table prone lateral X-ray. This is the position we give to the baby. We wait for 16 to 24 hours so that adequate amount of gas is reached into distal part of rectum. Then we give this position and take X-rays from lateral, which are centered on the greater trochanter. This is how we get X-ray. So here there is a pubic symphysis, which is seen as a boomerang shaped bony opacity. This is the lowermost point of the sacrum. Okay, so 0.5 centimeter just below this point, we keep it as a coccyx. So the line joining these 2 points is called as PC line, and there is one line which is drawn parallel to this line, which is going from the joint joint between upper 2/3 and lower 1/3 of the ischial tuberosity. So this is called as eye line. If the gas shadow is above this PC line, that is high anomaly. If the gas shadow is between these two lines, it is intermediate anomaly. And if it is below this eye line, that is low anomaly. So according to these X-rays, we plan our further management. Then another investigation is pressure augmented distal colostogram. So as we in general surgery, we do distal colostogram, but this is something different. Here most of the time the pouch is blind, or there is a small fistulous opening between rectal pouch and the urogenital system. So we put dye under a pressure so that the muscle it will distend the rectal pouch and open up the fistula, so that we can get exact location of fistula, and depending on that location of fistula, we decide the approach of our surgery. So these are a few cases. So this is a baby with high anomaly. This is his cross table prone lateral X-ray. We can see the shadow is much above. There is meconiuria. This patient is having hypospadias, meconiuria, and flat perineum, or rocker bottom perineum. It's like rocker bottom chair. And this patient in neonatal period, we did a transverse colostomy. So this is patient with intermediate anomaly. So here in this cross table X-ray, you can see this gas shadow is much below. Okay, this is coccyx. Here it is a pubic bone. So if we join this line, it is below PC line. Here the perineum is not very well developed, but it is better than previous X-ray. In this patient, we have done high sigmoid colostomy. Now this is a case of low anomaly. This patient came to us at 1 year of age with suspected Hirschsprung disease. Nobody have done his per rectal examination or per anal examination. So on examination, we found there is a stenotic anus, only permitting 8 French infant feeding tube. We did contrast study, which can be seen there. It is loaded with the feculomas and ectatic rectum. This is another patient with low anomaly. So this patient is having perineal fistula. So well-developed perineum, deep perineal groove, and this is intraoperative picture. You can see this is his fistula, and from here there is normal caliber rectum. This is female patient who is having anteposed anus. There is anus is in the anterior. This could be the normal position of the anus, but here there is a strip communicating between the fourchute and anus, and this is vestibular fistula. The rectal opening is right there in the vestibule. So here is the urethra, vagina, and this is vestibular opening. Hello, excuse me.
Yes, sir, I'm fixing.
Yes.
So this is also a vestibular fistula. You can see there is a catheter in the urethra. This is intraoperative picture just before OT. Here is the vagina, and here I have put infant feeding tube in the vestibule. Sorry, fistula. So this is fistula from inside during surgery. So this is a common cloaca. You can see there is a single opening, no anal opening, and this meconium is coming right from this thing, vestibular opening. And you can see the genital is smaller as compared to normal female genital in neonatal period. So these are the pictures of distal colostogram. Usually we do cologram for the patients who are having this thing, colostomy, and usually male patients. But this is done for a female patient which was presented at 6 years of age. She is having vestibular fistula, and the opening was inadequate to pass stool at this age. It can be okay till 6 months of age, but 6 years is too much. So the colon was hugely dilated. We did colostomy. Then after 6 weeks, we repeated this colostogram. So you can see this is dilated, very much dilated rectum. This is rectal ectasia, and fecalomas can be seen. Okay. Now this is a male patient where high sigmoid colostomy was done in neonatal period, and this is pressure augmented colostogram. You can see nicely distended rectal pouch, and here there is a fistulous communication, if you can appreciate. So there is fistulous communication between, this is urethra. So there is fistulous communication between the bulbar urethra and rectum. So we will operate this patient from perineal approach. This is another patient which is having a high anomaly. So you can see the right transverse colostomy was done in neonatal period. This is a colon, this is rectal pouch, and it is communicating with the prostatic urethra. So we will start our procedure with perineal approach. If we couldn't find fistula, or if it is not possible, we will go from the abdominal side. So here this dye is going right into the bladder. So fistula is possibly very big. Now surgeries. So there are many surgeries described for this thing, anorectal malformation, but commonly done surgeries posterior sagittal anorectoplasty, which is usually done in male patients, which is described by Albert Pina and Peter de Veris. So this is standard surgery for ARM. It can be done in almost all ARM except high ARM, where abdominal approach is required. So rectovestibular fistula in females, rectourethral bulbar fistula, rectourethral prostatic fistula in males, and imperforate anus without fistula. So in all these conditions, we can do this surgery. So the patient is given prone position. The principles is division of sphincter muscle complex in midline, then division of the fistula if present, then pull through of rectal pouch and anoplasty. So this is the position we give for the patient. This is intermediate variety of ARM. The patient is given prone position and fixed after adequate padding. Then painting is draping it done. In these cases, we catheterize patient in supine position. If fistula is very big, we may have problem in catheterization. In that condition, we have to use cystoscopy. Once the patient is catheterized, we give him prone position, fix it, and then the midline sphincter muscle complex is marked. So these sutures are where the sphincter muscle complex is marked with the help of muscle stimulator. Then midline incision is made from tip of coccyx to the sphincter muscle complex. So this white thing which is seen is called as endorectal fascia. These muscle fibers are called parasagittal muscle fibers, and here are the sphincter muscle fibers. So this is rectal pouch. So this is rectal pouch which is opened, and you can see a fistula there. Once this fistula is visualized, we take a submucosal incision here. Then we do submucosal dissection for 0.5 to 1 centimeter, because there is common wall between urethra and rectum at this place. And full thickness dissection of rectum will result into injury to urethra and urethral stricture in future, which will be very difficult to repair in this patient. So this should be done very carefully. Once the submucosal dissection is done for 0.5 to 1 centimeter, we go full thickness and separate rectum from the urethra. Once this is separated, here the fistula is closed from inside with the help of vicary sutures. Once this is done, then we mobilize this rectum circumferentially. Still adequate length is achieved. Once the adequate length is achieved, that means the length to reach sphincter muscle fibers, we stop dissection and we place this rectum within the limits of sphincter muscle fibers. So this was the marked sphincter muscle, and this was the posterior limit, this was the anterior limit, and we fix this rectum within the limits of sphincter muscle fibers. This is the subcutaneous tissue, and these are the parasagittal fibers, or you can see in adults or normal patient, these are called as this thing, levator ani. And this is after completion of procedure. Here is the anal opening. So this patient is on follow-up, very good continence and functionally doing well. Now this is a high ARM. So in high anorectal malformation, where the fistula cannot be approached from the perineal dissection, we do abdominal perineal approach, where we divide this thing fistula from within, and we directly dissect the sphincter muscle complex and pull rectum through the this thing sphincter muscle complex. Now this particularly, this is a patient who had a pouch colon which has been resected at another hospital, and this patient came to us for the definitive surgery. So here, if you can see, there is a stoma which is end colostomy. We directly mobilize this end colostomy and pulled it through the sphincter muscle complex. This patient is also having a very good continence right now, though this is colon and the sphincter muscles are poor. With the help of repeated bowel washes and bowel training, this patient is also doing well. So this is completed anoplasty. Now this is a female patient who had a rectovaginal fistula. Rectovaginal fistula is a very rare anomaly, and many people mistakenly take it for the rectovestibular fistula, which is very common anomaly. So in this patient, we have given prone position for PSARP. Now this is we did dissection like PSARP, and here is the rectovaginal fistula. If you can see, there is a catheter going right from the fistula and coming out of the vagina. This is completed procedure. We close stoma for this patient, and she is also doing very well. Now vestibular fistula. So for vestibular fistula, we can do PSARP or ASARP. ASARP is the anterior sagittal anorectoplasty, where the incision is on the anterior aspect of the sphincter muscle complex. So this can difficult for dissection and reconstruction, but better for anesthesia point of view, as patient is in supine position. So usually we do primary procedure if patient is on our follow-up since birth. But if sometimes patients are presented very late. So as I have shown you that this thing, cologram of 6-year-old female. So in such patient, we have to do colostomy. So this is a patient, a 2-month-old patient with vestibular fistula. So we directly did a primary ASARV for this patient. This is urethral opening, this is vagina, and this is vestibular fistula. So this is the pulled rectum after dissection, where we fix it within the sphincter muscle complex. Sphincter muscle complex is marked with the help of this sutures. And then perineal body is constructed here, and procedure is completed. This is completed anoplasty. So now this thing, complications of anorectal malformations and redo operations. So Group A is the patient which are having fecal incontinence and who require reoperation. So most of the time, the patient where the anus is not placed, rectum is not placed within the limits of sphincter muscle complex, or due to post-operative infection, there is wound dehiscence and rectum migrates out of the sphincter muscle complex. In that patient, we need to do this thing, reoperation. Or sometimes the patients are having very high anomaly and poorly developed sphincters. Then redo operations are recommended for those who are born with malformation associated with good prognosis. Means those who are associated with high anomalies or very poor muscle function. So these operations are not done, and they are usually managed on bowel management program. So which is altogether a very different topic. Then the rectum is completely mislocated. Then intact rectosigmoid. As in the previous talk, sir has told the function of reservoir function of rectum. So if reservoir function of rectum is there, we can achieve very, even very well-trained distinct patients, we can achieve continent even with the colon. The patient must have normal sacrum, because normal sacrum means there is normal neurological innervation and intact sphincter mechanism. Now, group B is the patient who are having post-operative complications like wound infection, femoral nerve palsy because of positioning of patient, then rectal problems like dehiscence, retraction, infection, or acquired atresia, and recurrent fistulas like rectourinary fistula or rectovaginal fistula. Then many patients have persistent sinus. Means if the fistula is missed during surgery, then it will be persistent fistula or sinus, and if it is occurring again, that is recurrent fistula. Then posterior urethral diverticulum, which is because of the, when we divide fistula, and if you leave very big rectal tissue on the urethra, we will get posterior urethral diverticulum, and this is very problematic thing to manage. Then urologic injury, many times if we don't get a proper plane, there may be injury to vagina or urinary bladder. Then neurogenic bladder, which can be seen post-operatively, or it can be associated with the anorectal malformation. As during surgery we do presacral dissection, this may injure neurological supply of the bladder. There is a lot of dissection near the bladder neck where the plexus is situated. So many patients may have neurogenic bladder, which can be temporary or which can be congenital and permanent. Then in laparoscopic surgery, in cases of high anorectal malformation, we can do laparoscopic pull through also. So laparoscopy associated complication can be seen in those patients. And rectal prolapse, if the muscles, the sphincter muscles are not very strong, or the fixation is not proper, in that case we can have rectal prolapse, which can be excised, and redo anastomosis or anaplasty can be done. Now, group C is the complications from mismanagement of constipation. So what is mismanagement of constipation? So low anomalies, these are associated with the very good continence, but they are having problem of constipation. So as there is constipation, they may lead to soiling, which is misinterpreted as incontinence, but that is actually a pseudo incontinence. So if we can manage this constipation properly, we can avoid that pseudo incontinence, and patient can lead normal life. Post-operatively, we have to put patient on dilatation program, because this new anus which we create, these are having tendency to restenose. So when the patient is on, especially on colostomy, we have to do dilatation up to the point where we can have normal, the size of the anus normal for the age. And once it is normal for the age, we go ahead for the stoma closure. Then management of incontinence in case of very high anomalies, like the patient who are having very short colon, or directly we are pulling ileum. In that patient, we have to do management for incontinence. Then management for constipation, especially in the low anomalies or intermediate anomalies, this patient is having very high rate of constipation. That means almost all patients, they are having constipation. So very important to manage this constipation, especially in early post-operative period, and rehabilitation. All this comes under rehabilitation. So we do this for years, almost 2 to 3 years of age. And once they are bowel trained, they can lead normal life. Thank you. Thank you very much. Any
Thank you so
questions?
much, Kiran sir. Yes, sir. I would like to ask all the participants to post their questions in the chat box if any question. I would also like to thank Dr. Kiran sir. Thank you for explaining everything right from the diagnosis, the basic presenting complaints of the patient, radiological investigation, for explaining how intricate and basic X-ray plays a role in diagnosing ARM, everything from basic stages of ARM to the types of ARM, and as well as particular treatment for types of ARM, and along with the complications and the management of complications. Thank you for putting it up in such a concise pattern. It would be really helpful for us. Thank you, sir.
Dr. Kiran, thank you for an important topic of pediatric Colo-Proctology and congenital anomalies associated with Colo-Proctology. Thank you. Thank you. It was nice to hear you.
I would now like to request Dr. Rajesh Gattani sir to conclude this CME along with the vote of thanks. Handing over to you, sir.
It was a nice day as well as hectic for all of us. To conclude with seminar, I, Dr. Rajesh Gattani, would like to start by thanking our patron, respected Shri Dattaji Meghe sir, Chancellor and Founder, DMIMS, deemed to be University, and Dr. Ved Prakash Mishra sir, Pro Vice Chancellor, Dr. Lalit Wagmare sir, Pro Vice Chancellor, Dean sir, Dr. Sandeep Srivastav sir, and our very own Dr. Chandrasekhar Mahakalkar sir, CMS sir, for constant encouragement and guidance and providing us with this golden opportunity to organize the CME on very important topic, that is Colo-Proctology. I also would like to thank our organizing chairman, Dr. Lamture sir, Head of Department of Surgery, Dr. Shinde sir, and our organizing secretary, Dr. Tushar Naktode, for taking initiative to arrange the CME in a very short period of time and giving us this wonderful platform for discussion on important topic in Colo-Proctology. Then I would like to thank our senior faculty members, professors of the department, and the honorable speakers, Dr. Suresh Chandak sir, Dr. Pankaj Ghade sir, Dr. Harshal Ramteke sir, Dr. Kiran Khedkar sir, Assistant Professor in Pediatric Surgery, our Assistant Professor, Dr. Sanjeev Gyanchandani, and special thanks to Dr. Meenakshi Yola Madam, our very own former HOD and currently additional professor in AIIMS Mangalgiri, along with Dr. Nikhil Pandey sir, consultant oncologist in our own hospital, that is AVBRH, who took out their precious time to enlighten us and define intricacies on such important topic of Colo-Proctology. I would like to thank MMC observer, Dr. Makarand Vevare sir and Dr. Vaishali Vevare ma'am for guiding us. Last but not the least, I would like to thank our technical support team, Dr. Harshal Taide, Dr. Chetna Rathi, Dr. Shiti Maholi, and other PG students who contributed in making this CME a grand success. Thank you all for such a wonderful cooperation, and thank you our patron for wonderful guidance. Thank you very much.
I would like to mention a few points. The certificates of the CME shall be handed over in a period of 2 weeks through mail, and everybody is requested to hand over the feedback forms that we shall be sharing with you. I would finally hand over the session to Dr. Tushar Naktode sir, the organizing secretary of the CME, for his final note to the CME. Thank you, sir. Over to you, sir.
Thanks to Dr. Gattani sir
for such a kind words and enlightening us with the common but important topic, that is hemorrhoid. Thanks to our HOD sir, Dr. Lamtoya sir, for giving us opportunity and guiding us for conducting that CME. Thanks to Dr. Harshal Tade, who has given us a very important technical support and also guidance regarding the conducting CME. Thanks to Dr. Roshni, Dr. Shruti, and Dr. Chetna for helping me out to conduct the CME so smoothly. And lastly, thanks to our delegates who has registered for the CME and making it successfully. Over to you, Shruti.
Thank you to all respected patrons, speakers, delegates, and my dear friends for bearing with us and being a part of the CME. Thank you so much for making it successful.